Good morning, councillors, ladies and gentlemen. It is 10 o'clock on Monday, the 1st of August, 2022. And may I make my congratulations to the Lionesses in their win last night of the 2022 Euros. So welcome to the County Council buildings for this meeting of Staffordshire's Health and Care Overview and Scrutiny Committee. I am your chair, County Councillor Jeremy Pert. Gentlemen, you may remove your jackets due to the temperatures in here and the breathlessness in here and whatever the equivalent is for ladies. May I remind you that today's meeting is being recorded, and for those who want to watch it back, the recording can be found on the County Council's website. The meeting is also being beamed live for people to be involved with and will cut off 20 seconds after the equipment has stopped. All voting committee members are in the chamber, in the room, in the oak room, in person, and there is a variety of people, both virtually as our guests. So can I thank our guests for their input so far? Today there is one substantive item agenda, and we want to go through that in detail to satisfy ourselves of the rigour and thinking that has gone into this, as it will shape mental health services in the south of the county for the best part of a decade, I'm sure. Therefore, can I make a couple of comments, which is, for our presenters, I'm relaxed about the length of time that you use for your opening comments, and I am aware that you have a presentation for us, and obviously that's within reason. And equally for committee, if we can try and group our questions into themes, then I will try and bring people in dynamically to stick within the same theme so that we can go into detail on a theme and then start another theme rather than go a bit haphazardly around the discussion. I'm sure you'll know what I mean. Second of all, can we focus on the tangible outcomes for the residents of Staffordshire? Let's use data and our expertise and experience to sharpen the quality of debate and scrutiny so that we can provide assurance and reassurance that things with the health and care system in Staffordshire are going in the right direction and the one we'd want to see for our residents. Before we invite our presenters to speak, it might help committee if I provide some background to today's item, and I'm reading directly from the paragraph on page 409 in today's pack, which starts, until February 2019, the George Bryant Centre provided inpatient mental health services to people living in Burton-on-Trent, Lichfield, Tamworth and the surrounding areas. The George Bryant Centre's West Wing had 19 beds and provided inpatient care and treatment for adults aged 18 to 65 with severe mental illness. The East Wing had 12 beds and provided inpatient care and treatment for older people, 65 and over. Most of those were people living with dementia. On the 12th of February 2019, a fire destroyed the West Wing. Anyone in the West Wing at the time of the fire was transferred to St George's Hospital as an emergency response. The Board of Midlands Partnership Trust, the Foundation Trust, MPFT, made the decision later in February to temporarily close the remaining East Wing, which was enacted in April 2019 after patients were either discharged or transferred to the most appropriate care setting according to their needs, including home. Since the fire, anyone in the local community, in the local area, referred for mental health support has been treated in the community through an enhanced mental health service offer, or where clinically appropriate, admitted to an inpatient bed in St George's Hospital. Since July 2019, MPFT clinicians and staff have been working to find the long-term solution for the two inpatient services that the George Bryant Centre delivered. So that's the background to today. I would say that with some 608 pages to digest prior to the meeting, it is sometimes more difficult to get to the real questions that need to be focused on, as you can get blindsided by the volume of information. And the authors of the business case would want you to focus on the elements that they feel are of note, which may not always be the relevant concerns for committee or our residents. So I think there are two sets of issues in my view, and I just want to make a couple of comments around those. First of all, we should be clear that there are a range of different bodies around the table. The integrated care system, the successor body to the to the clinical commissioning groups is the commissioner of the services. They are the ones with the money and decide what services need to be provided for our residents. And an MPFT, Midlands Partnership Foundation Trust, is the provider of the services. And we should be really clear between the distinction between the two. The MPFT have ratified the proposals, but the ICS are yet to do so, and nor has NHS England and infrastructure. So this is not agreed, and we need to make sure the provider does not decide the agenda themselves, rather than the commissioners and the residents deciding the agenda. Second of all, we need to be clear that there are a couple of issues. One is about the process, how we come to be here today with a business case that has effectively only got one option in it for consideration. And second of all, the recommendation itself. In relation to two elements, the elderly patients with dementia who were originally housed in the East Wing, which is not particularly referred to in the business case in much detail, and then other mental health inpatient services in the south of the county. So I will leave my comments there if I may, but I think people will probably see where I'm trying to get to. So let's start with the agenda itself. First of all, apologies.
Yes, Chairman. Apologies have been received from Councillors Charlotte Atkins, Patricia Ackroyd, Rosie Claymore and Anne Edgeler. And Councillor Daniel Maycock is in attendance today as a substitute for Rosie Claymore from Tamworth.
Thank you. We've seen you before, Daniel, so welcome and thank you for joining us. Item 2, declarations of interest. Do we have any declarations of interest relevant to this morning's agenda, please? Daniel.
Thank you, Chair. With the George Bryan Centre being in Tamworth, Phil, I need to declare an interest there. Also, I am previous service user and current as well.
Thank you, Daniel. Can I just check that's not a prejudicial interest in terms of you taking part in today's debate and discussions?
No, it's not, Chair.
Appreciate that. Thank you. Richard.
Thank you, Chairman. Previously, over 10 years plus, a family member had been a patient, but I have recorded that previously when the George Bryan has been referred to.
You have. Thank you, Richard. And I'm assuming it's not a prejudicial interest which precludes you from taking part in today's discussions. Thank you. Do we have any other declarations? No, we're not. No, we haven't. So let's move on to item number 3. So, Steve, we're with you and your colleagues. Do you want to introduce everyone first? I'm assuming you're leading on this. Do you want to introduce everyone first and then take us away with your presentation?
Thank you very much, Chair, and hello, good morning, everybody. I think we'll just say hello before we get into the main crux of the presentation, where I'll hand over to Dr. Paul Edmondson-Jones. I think first, colleagues and foremost, thank you for joining us today and sharing our passion for mental health in the community and in an inpatient setting. This is a really important subject and topic for both our populations and ourselves as providers. And it is really good to know that we have colleagues in your council chambers at the moment with lived experience, but also with the same passion that we have. So, Chair, I'll just, without further ado, just introduce my colleagues. What I'll do with your agreement is I'll introduce myself and then name my colleagues in the order that they come so they can introduce themselves. So I'm Steve Grange. I am Deputy Chief Executive and Director of Strategy for Midlands Partnership Foundation Trust. And can I hand you to Dr. Abid Khan?
Good morning. Thank you for having me. My name is Abid Khan. I'm the Medical Director for Midlands Partnership Foundation Trust.
Thank you, Abid. And Helen Slater.
Good morning. My name is Helen Slater and I am Head of Transformation for the Staffordshire and Stoke-on-Trent ICB.
Thank you. And Jenny Fullard.
Morning, Jenny Fullard. I'm the Communications and Engagement Service Partner working with the Integrated Care Board.
Thank you. Lisa Agel.
Good morning, everyone. I'm Lisa Agel. I'm the Operations Director in Midlands Partnership Trust with responsibility for mental health services in the South and unplanned care across the county.
Thank you, Lisa, and thank you for joining us today. Obviously, you're in clinic at the moment, so colleagues, I think a couple of us are in the hospital setting, including myself, so please forgive us if we have to put masks on or turn our cameras off. Nicola Bromwich.
Good morning, Nikki Bromwich. I'm Head of Strategic Commissioning for the Stafford and Stoke-on-Trent Integrated Care Board.
Thank you very much. And I'll hand over to Dr. Paul Edmondson-Jones, who will introduce the session and obviously, first of all, introduce himself. Paul.
Thank you, Steve, and good morning, Chair. Thank you for having us here today. I'm Dr. Paul Edmondson-Jones. I'm Chief Medical Officer for the Integrated Care Board. The reason that I'm leading the presentation today is that the final decision-making responsibility for service transformation under the Health and Social Care Act rests with the NHS Integrated Care Board. We've got a duty to engage with you as the Overview and Scrutiny Committee, and this meeting therefore follows the update that we gave in March. Now we've been able to work further through the appraisal process. Part of that has included engaging with the West Midlands Clinical Senate, and we've also had discussion at the MPFT board, as you know. This morning, you'll see on the slides, Jenny, I think, are you putting the slides up? You'll see on the second slide just outlined what we're going to cover today. But essentially what we're going to do is take you through the clinical model that's informed the current process and the process we've taken so far, and then talk about what happens next. Do want to just emphasise, Chair, what you said at the beginning. Even though MPFT have agreed their business case, no formal decision has been made by the Integrated Care Board at this point. There are quite a number of further steps in this process we need to go through before the ICB can even consider a decision, and we'll talk about that as part of this presentation. And just finally, I know that councillors will have lots of questions. If we could just run through the presentation first, it may help to answer some of those questions, then we can go back to the slides if you wish to later. Probably take, I think, about 30 minutes to go through the slides. And if it's all right with you, Chair, I'll hand back over now to Steve Grange, who's going to start us off on the presentation.
Thank you.
Thank you, Paul, and again, thank you, colleagues, for introducing yourselves. The caveat there, Chair, I think, please forgive me that, as I said before, a number of us are in the hospital at the moment and may need to either switch our cameras off or don a mask in case of any emergencies. So, colleagues, I want to take you back to the 12th of February 2019, and a couple of us were gold on call. Myself and our chief executive and a number of our clinical colleagues were silver on call, and we were notified quite late into the evening that a small fire had broken out at the George Bryan Centre. That rapidly escalated to a more significant fire, and the picture on the right-hand side of your slides shows you the extent of what was an incredibly traumatic evening for the staff and our patients and the public around that area. The fire destroyed most of, if not all of, the East Wing, and as you can see, completely uninhabitable. And I would take you back to the 12th of February by saying that at the point when the hospital was ablaze, a number of our staff went above and beyond. They saved patients, they evacuated effectively. They put their own lives at risk, as they have done actually over the last several years with COVID-19, but they put themselves in front of harm's way to make sure that patients and their loved ones were protected. And they did that incredibly effectively. A number of them went above and beyond. Some of them received commendations from the Board of Directors for their bravery and their commitment to mental health and patients. Fortunately, there was no lives lost on that evening. There was, however, an extended amount of damage, and as you can see from the building needed to be closed down for safety reasons, and therefore, as the board, we took a decision that we needed to temporarily close that so that patients could be seen and supported in a suitable, if not more suitable, environment. So the chairman has already indicated the West Wing had 19 beds for people aged 18 to 65, and the East Wing had 12 beds for people aged over 65, which were older care and dementia. My colleagues will go through that detail with you shortly. Any of you know the George Bryan Centre or have been a resident there or have visited there, you will see that it has a reasonably close proximity to another hospital. However, that hospital is a different sector, and what we would say by sector is that it is a community physical care hospital and therefore doesn't have any expertise around mental health in the same way that some of my colleagues are joining you today. Our medical director and our operations director for planned care are both clinicians, and I would say this because I'm biased, but they're both excellent clinicians as well. And you'll realise that people with a qualification need to make sure that they are able to support patients in the way that they're qualified to. So the proximity to Sir Robert Peel and surrounding areas sometimes can be confusing because we say that the building is isolated, and in this case it is, but it's isolated away from similar practice and qualified care that would be needed for those patients. So if I move to the next slide, the milestones and the timeline that we started through our process has been pretty extensive. We have engaged and reached out to our public and patients and our staff during this process, but arguably we did start this and this process before the fire. However, the fire made us take a temporary check on what was happening with the future of our inpatient services, and our listening exercises and options appraisal process started in the autumn of 2019. Now, my colleagues from the ICB will go through this in more detail with you, but it's been extensive. One of the things that obviously stopped us doing this at the speed and pace that we would have liked to have done, of course, was COVID-19. And again, I am extremely biased when I put my hand on my heart and say every single one of our clinical members of staff continued to go above and beyond to protect life and to make sure that people suffering from mental health, learning disability, autism, children and young people, and some of our older age services were protected during the pandemic as best as possible. That made us, unfortunately, stop some of our more corporate events, including the options appraisal, where we had to pause to respond to the pandemic, as you would expect that would be entirely appropriate. So the timeline that is presented in front of you will go through in more detail. And if I can move to the next slide, please. This video is going to give you an indication of our journey to date and probably says it much better than I do, Chair. So Jenny, would you start that, please?
The George Bryan Centre used to provide inpatient mental health services for people living in South East Staffordshire who needed care in hospital. The West Wing had 19 beds for adults with severe mental illness. The East Wing had 12 beds for older people. In February 2019, a fire destroyed the West Wing and patients were transferred to St George's Hospital in Stafford. It wasn't safe to keep the centre open for only one ward. So, Midlands Partnership NHS Foundation Trust decided to temporarily close the East Wing. Patients were moved to a place that met their individual needs. Since the George Bryan Centre closed, we've provided enhanced community mental health services. For example, we now have integrated neighbourhood mental health teams who can give more joined-up care and provide more help for people to stay at home and be looked after within their community. However, there will be times when a hospital stay is needed, when people are very unwell and need intensive treatment. Since the fire, we've been considering how to provide services for people with mental health needs living in South East Staffordshire. One proposal is to have all inpatient beds at St George's Hospital. The other is to provide 18 inpatient beds on the site of the George Bryan Centre. Both proposals include keeping and further developing our enhanced community services. We've involved patients, the public and staff throughout the process to develop our proposals, although we had to pause this work while we responded to COVID-19. And we've shared all of your views and suggestions with the team working on the proposals. During the options appraisals process in late 2019, early 2020, we checked if the proposals met the essential criteria. In December 2021, we held a technical event which looked at the findings from the involvement exercises, clinical evidence and changing national guidance. Based on this, we found that only one proposal for inpatient care was going to be viable. This is to have all inpatient beds at St George's Hospital. However, no final decision has been taken. We are still developing our business case, and there will be other opportunities to get involved.
Thank you, Jenny. And Chair, I think that it's always very sad when a video can do a job better than you, but I think the video really captured everything about what we were trying to achieve and continue to try and achieve here. Safety, clinical quality and the service that we provide to our patients is something that we're incredibly proud of and is really important for us as a mental health and specialist trust. As you'll know, that we also provide now physical care through our services in the community, but this proposal today, this conversation is based around our mental health services for the population of Lichfield and Tamworth and East Staffordshire. So the criteria for assessment of our proposals, the video did describe our proposals, and we realised from an experience point of view the viability of proposals needed really to meet some essential criteria. The first, probably the foremost and most important, was the clinical sustainability of the service and the offer. Anyone that has been a resident of ours or anybody that I'm sure has visited would hope and want for the service to be safe, to be caring, to be effective and to be well led. It also needs to be able to be responsive, and in order to do that, that's formed our essential criteria. Strategic fit nationally, that was really important because our best practice and national best practice is something that we take very seriously. And then third, which of equal importance, is that it does meet local needs and that local people are not disadvantaged by the service that we offer. In fact, do get the need that they require as best as possible. We also included some additional criteria around workforce to make sure that we had the right workforce to support the services as it was developing and as more services continue to develop. And that included a review of the demand and activity from the services and the resilience of that in terms of what came through the front door and what we needed to provide, and activity within the ward. And my colleagues, particularly Lisa, will go through some of the difficulties that we experienced with the George Bryan Centre, as was, and that then finally some of the additional criteria would be the inclusion of the estate itself. So if I can move to the last slide, this is just a picture of what the video described, 4 segments to this: 2019 before the fire, 2019 after the fire, our initial proposals, which were in 2019 in autumn, and then our review of the proposals post-pandemic, which is leading us to a conversation with your good selves today, obviously leading up to 22. And as Dr. Edmondson-Jones had indicated, and the board of MPFT have indicated, no decisions have been made. The decisions that we've made in this respect are to move to the next stage of the process. So therefore, no decisions have been made on the future of these services without going through the appropriate engagement with yourselves. So can I move to the next slide and hand you over to Lisa Agel, who's the Operations Director for MPFT. And Lisa, thank you for joining us today. I know you've got a very busy clinical day, so can I hand over to your good self?
Thank you, Steve, and thank you, Chair, for allowing us to come and talk about this important subject. Whilst I'm delivering the presentation, Abid Khan, who is our Medical Director and Consultant Psychiatrist, is also on the call with us, who will support any questions, particularly about the clinical model. Can you move to the next slide, Jenny? Thanks. Okay, so a strong driver for the proposal to make permanent the temporary consolidation of inpatient services at St George's Hospital is that community mental health services in South Staffordshire have been transformed over the past 4 years in line with the national plan. This aligns community mental health services in South Staffordshire not only with the plan, but also with the National Mental Health Strategy and the support of evidence-based practice, to really help and support patients better by caring for them in their communities as much as possible, with inpatient stays only where there is no alternative. As Steve mentioned, since the fire at the George Bryan Centre in February 2019, patients from South East Staffordshire who need to be admitted to hospital for assessment or treatment have, with a few exceptions, been admitted to the wards at St George's Hospital. Between 2017 and 2019, the average length of stay for patients in the George Bryan Centre by ward was around 30.62 days. Since the fire, when acute inpatients moved to St George's Hospital and we've developed our services in the community further, the average length of stay for our acute inpatient wards has fallen to 22.94 days, which is a really good length of stay for mental health services and certainly where we would want to be. The number of beds required is assessed on a regular basis by a centralised bed manager. The inpatient services for adults with severe mental illness are supported by both a comprehensive community service, which helps to reduce the length of stay to a minimum, but also the ability to access specialist inpatient mental health beds. And this reduced length of stay really illustrates the successful approach of community-based services. The size of St George's Hospital site enables a much greater range of specialist services that the George Bryan was able to offer. So there was a whole range of services that even when the George Bryan Centre was open could only be accessed at St George's Hospital in Stafford. So things such as an ECT facility, specialist allied health professionals, and a range of specialist wards where care could be stepped up or stepped down as appropriate. Moreover, patients often needed to travel to St George's Hospital to receive therapy when they were inpatients at the George Bryan Centre, particularly if their condition deteriorated and they needed to be transferred to St George's Hospital, where our psychiatric intensive care unit is. The centre's distance from Stafford made responding to psychiatric emergencies difficult, so there was an over-reliance on support from the local police. Transfers could take up to 6 hours because of the need for secure travel, and the relative isolation of the centre had real implications for both staff safety, quality of care, and for recruitment. So in terms of clinical quality and safety, therefore, as described, the location and the facilities at St George's Hospital offer many strengths, both to our workforce, but more importantly to our patients. Following the fire that destroyed the George Bryan Centre, the care of patients who would have occupied the beds in East Wing, which is primarily dementia patients, was transferred to a community-based model. This is supported by national best practice and clinical evidence. And a team was already in place for older adults with dementia, providing multidisciplinary support both in a person's home, but also in a care setting. So people with dementia could be supported in their own environments and their carers could be offered that support and reassurance when needed. A team for older adults with severe mental illness was put in place. This included enhancing our crisis home treatment team, which is a 24-hour, 7-day-a-week, 365 days a year service with skilled, experienced older adult specialists. There was addition of nursing and therapy leads and a particular focus on clinical psychology in line with evidence base. There's also a hospital avoidance team and a wider community support as described earlier. There's clear evidence that providing care to older adults through community teams produces better outcomes. This is not just the case for mental health services, but also physical health care services too. National and local policy and research evidence indicate that this is a better method of supporting this cohort than an admission to hospital, where we know the likelihood of deconditioning and risk of long-term care is much higher if they have a hospital admission. Next slide, please, Jenny. For most people with severe mental health problems, their illness is not the only thing that they need help with. They need mental health services that go beyond treating symptoms. The model is for holistic, person-centred care with services that are joined up. And this has been the focus of the development of our community services. So really thinking about how primary and secondary care need to work together, because joined up services make it easier for people to get the care they need in their own communities. Healthcare and social care need to work together because people's social needs can affect their mental health. Mental health care and physical health care need to be looked at together too. The new model is inclusive and aims to ensure equality of access, experience and outcomes for people from all backgrounds. It also calls for a real shift in our culture, with service users and carers becoming much more involved in how care is designed and delivered in a co-produced way. Care is given at home and in the community wherever possible. Inpatient care is only used when essential, when a person is so unwell that they need intensive medical treatment and care that can only be delivered in a hospital setting. Next slide, please, Jenny. So the clinical evidence I've alluded to for people, both with people with a severe mental illness and people living with a dementia, hospital should be the last resort. We should be focusing on supporting people in their own communities, around their own support networks to enable them to be able to live that full independent life, really thinking about how we support recovery, but also making sure that they have meaningful occupation as part of that offer. Next slide, please, Jenny. So our model is based on a stepped care model, which is very common in mental health services. Stepped care is an evidence-based staged approach to the delivery of mental health services, comprising of a hierarchy of interventions from the least intensive, which is self-care, self-help, which is where we really want to focus and support people in their local communities, matched to those at the most intensive need of intervention, which is inpatient. So really thinking about how we support people in those lower tiers of stepped care so that inpatients is for as few people as possible, but also for as short a stay as possible. Thanks, Jenny. Next slide, please. So in terms of the focus of enhancing our community mental health services, in line with the National Plan for Mental Health, we've been making changes across Staffordshire on how to deliver our community service so that we can support people to recover and stay well in their home and community, avoiding hospital admissions that could take them away from support networks and risk that loss of independence, but also increase the risk of deconditioning. We want older people, adults and young adults in Staffordshire to feel supported, whether they find themselves in crisis or simply want to maintain their day-to-day mental health and well-being. The changes we've been making are based around the guiding principles of improving access to care, making it clear, simple and quick to get support when needed. Using a trusted assessor model, thus removing the need for service users to retell their story every time they receive care, being flexible and personalised, focusing very much on safety. The service must be safe for service users, carers and our staff. One digital care plan that everybody inputs to but is owned by the service user, a named worker that not only supports but coordinates the care, integration of care through collaboration with relevant partners and aligning to community sector support has been a real shift in focus. And lastly, supporting physical health needs alongside mental well-being. We all know that the evidence tells us that for those people with a severe mental illness, they're likely to die 25 years earlier than the rest of the population. So a real focus on how we make sure we engage with people in their physical health as much as their mental health. This will be delivered through integrated neighbourhood mental health teams that sit at the heart of a community, working with the local voluntary sector organisations or primary care networks to give holistic support. These teams will make sure that people get specialist help when they need it. Next slide, please, Jenny. I've already talked about St George's Hospital, and you can see on this slide that on the hospital site we have upwards of 150 beds with a range of specialist inpatient services that people are able to access quickly. But it also gives our staff the opportunity for real development, which at a time where the NHS is really struggling to recruit clinical staff, this is a really attractive offer. It's a large hospital site with multiple inpatient wards and specialties for adults and older people, alongside a range of other specialist mental health wards. It's got a much bigger staff group, a much more focused multidisciplinary offer across the services that enables our staff group not only to have access to a wider skill mix, but also much more development opportunities and flexible approaches to working. Staff working within inpatient mental health services are highly skilled and specialist staff. They are difficult to retain, and certainly in the current climate, difficult to recruit. So we really need to focus on how we make sure we have a really robust offer for the workforce, because without our workforce, it impacts on our ability to deliver high quality services. We know from the evidence and from our experience of managing an isolated inpatient unit, it's really difficult to recruit and retain staff. And that was a real challenge that we faced at the George Bryan Centre. Next slide, please, Jenny. So what is our proposal for inpatient mental health service? Steve alluded to the fact that at the beginning of the process, we were reviewing two proposals. The first one was around centralising the 18 adult acute inpatient beds on the St George's Hospital site, which is where they've been post the fire. And the second proposal was around re-providing the 18-bedded adult acute at the George Bryan Centre site. Our focus for dementia patients is still to maintain a community offer of wraparound support in a person's home or in the care setting that they happen to be in, because we know that the evidence suggests that they will have much better outcomes with that model. Next slide, please, Jenny. So during a technical event that took place in December 2021, which Steve alluded to, each proposal was reviewed in detail by our experts. That included clinicians, staff, Health Watch and other partners. And we built on the learning from COVID-19. We've worked very differently throughout the pandemic. We've all had to adapt and really embrace digital technology, but also had to think about much more innovative ways of supporting our patients so that their well-being is maintained. So we've really been able to progress lots of very positive digital technologies that not only support our staff to work differently, but equally support our patients to have different types of access to services. We also reviewed the changing clinical guidance with the enhanced community support that we'd put in place for our dementia patients. And we've seen really positive outcomes from that, particularly through the support of our hospital avoidance team. Our expert technical group raised clinical safety and workforce concerns about developing a standalone site. And there was real recognition of the limited numbers of specialist staff and no psychiatric intensive care, particularly at a standalone unit. And what we've seen throughout the last 3 or 4 years is the acuity of our inpatients, but also the risk factors posed that we need greater access to psychiatric intensive care facilities. There was also a potential destabilisation of the workforce at St George's Hospital if an additional standalone site was established. Next slide, please. So following the technical event, the technical group agreed that there was one single viable proposal to be put forward, and that was the centralisation of beds on the St George's Hospital site. But that does require us to still focus on developing that real community offer, supporting people in their own homes, and that's the focus of the work we've been doing for the last 3 years. That didn't stop during COVID. But a real distinct enhanced service for adults of any age with severe mental illness and for the population with dementia. The George Bryan site was deemed by the technical group as a non-viable option because of the clinical safety issues raised and the viability of sustaining an isolated unit. Next slide, please, Jenny. Sorry, I just need to drink. So obviously there are positive and negative impacts of both of the proposals we're putting forward, and we've been through a detailed impact assessment that identified these. There are real positive impacts for patients, as the national best practice for treating patients with severe mental illness has moved from a bed-based model to a community-based model, supported by strong evidence for improved outcomes. Under this model, the number of admissions from all communities will be reduced, and that's certainly what we've seen in South Staffordshire. However, there will always be times when patients need intensive medical and clinical supervision and treatment that can only be provided in a hospital, and this needs to be of the highest quality. We will always still admit patients when this is the right course of action, and this cohort of patients will be admitted to an inpatient bed at St George's Hospital, Stafford. However, if we bring all inpatients into St George's Hospital, we do know that some patients and carers will be impacted by the requirement to travel further. Next slide, please, Jenny. This could adversely impact those who live in a rural area without good transport links and those within households without a car. And this is a particular factor we need to consider, particularly given where we are with fuel prices and cost of living. And the Trust is looking at ways in which to mitigate against the potential increased need to travel for carers and families of people from South East Staffordshire who do require admission to an inpatient mental health bed in Stafford. Previous suggestions from the 2019 involvement events included financial support for transport, pre-book transport and volunteer visitors. We will also continue to explore digital solutions, and that's something we've, as I mentioned earlier, we've really embraced in the last 2 or 3 years, but we know that that's not the answer for everyone. There are people that don't have access and will really need support with that, and there are also people that find it difficult to engage using digital technology, so we know that's not the solution for everyone. We would like to hear any suggestions anyone has around different ways to support families and carers who are having issues travelling further and experiencing difficulties, particularly in terms of longer, more difficult and expensive journeys. And it's really worth adding that the proposal is not something new, as we've already been admitting patients to St George's Hospital since February 2019 and have been providing an enhanced community health service. These services have been in place for more than 2 years. During that time, there have not been any adverse incidents or complaints related to the enhanced community provision. And we would also note that providing care at home wherever possible reduces the need for patients and carers to travel to access care. Next slide, please, Jenny. And I'm handing over to Helen now. Thank you for listening.
Thank you, Lisa. So I'm just going to take you through a few slides that talk through the assurance process and the statutory duties that we need to ensure that we're meeting as we go through the process. So next slide, please, Jenny. So in terms of any service change within the NHS, we need to ensure that we're following the statutory and regulatory requirements as set out in the Health and Care Act 2022 and other best practice. So there is a series of guidance within NHS England. The planning, assuring and delivering service change for patients is a key piece of guidance that we review on a regular basis to make sure that we're following each of the steps for those from that guidance. In terms of the statutory duties, these include the duties to promote equality of opportunity and to reduce inequalities in health outcomes. And I think the clinical model that Lisa has talked you through will help to you to understand what the model is trying to achieve in respect to those. Involving patients and local people in the development and consideration of proposals. In the table that was presented within the paper, that you received alongside the business case. There is detail in terms of the involvement activity that we've undertaken over the last few years. There's the 4 gunning principles that we need to take into consideration as we go through any formal involvement, which we'll pick up a bit later in the presentation. Government tests related to bed closures, that's outlined within the NHS England guidance that I've just mentioned, and consulting local authorities. So having that ongoing conversation with yourselves in terms of the proposals and the process that we're undertaking. Involvement throughout this is key, both with public, patient, stakeholders, the staff and the clinical teams that are involved in the service review and the service changes that we're proposing. There's no duty to conduct a public consultation on any proposals that are not viable. It would be disingenuous of us to put forward any non-viable proposals. And what we have seen in terms of UK courts have found against consultants who have included unviable options within any consultations that they've undertaken. So one of the elements that we've wanted to make sure throughout all of this is that we're making sure that we're following a fair and lawful process, and that we've highlighted through each of the stages and the different presentations that we've made to you over the last couple of years the process that we've undertaken, involve stakeholders in developing the options and appraising the options, and that's where we've linked through from both the expert panels through to the patient and public involvement sessions. Be transparent with our rationale and why the proposals are deemed unviable, and Lisa's just talked you through that, and remain open to any new ideas and information that might generate a better option, and also, as Lisa's mentioned, in terms of any of the mitigating factors against the impacts that we've identified as we've gone through this process. Next slide, please. So in terms of the NHS England guidance and meeting the government's test for service change, there are 5 tests that we need to undertake. The first 4 are around strong patient and public engagement, and this is outlined within section 5 of the business case that's been shared with you. Consistency with current and prospective need of patient choice, this is outlined in sections 2, 4 and 7. Clear clinical evidence base, this has been articulated today by Lisa, but is also outlined within section 2, and has also been independently reviewed by the West Midlands Clinical Senate in a review session that took place on the 10th of June this year. In terms of supporting proposals from clinical commissioners, the process and the clinical model has been taken through the ICS Mental Health Transformation Board and is due to go through the ICB board this month. But more details can be found in sections 5 and 6 of the business case. And then most relevant is in terms of the NHSE's patient care bed closure test, which must also be applied. This final test requires that NHS organisations that show significant hospital bed closures or location change are reviewing their proposals and demonstrating that a sufficient alternative provision, whether that be increased general practice input or community services as outlined by Lisa, are put in place to support any proposed bed closures, and that there is a workforce that's sustainable to maintain that service provision. So that is outlined within, in terms of section 2 and section 7. One of the elements that we did test out with the West Midlands Clinical Senate is bed modelling tools, and there is no national bed modelling tool for mental health beds. But as Lisa has mentioned, the bed numbers are reviewed by a specialist team on a regular basis for the whole of the Staffordshire area that the organisation covers. The proposals outline how the clinical model is supported by the enhanced community model, and the Trust have invested in terms of both a sustainable workforce to take the models forward, but also in a series of voluntary sector contracts that support that wraparound care that links alongside the clinical proposal. This is why the expert panel on the 10th of December agreed that there was only one viable proposal, moving to make permanent a model that has been in place for 3 years with the provision of the 18 beds on the St George's site. Next slide, please. So as Steve mentioned earlier, there's quite a detailed process that we've undertaken, and that started in the summer of 2019, where we presented the clinical case for change to NHS England and the West Midlands Clinical Senate at the stage 1 review. And this was followed by a 12-week listening exercise over the summer of 2019 and detailed involvement activity with that MPFT undertook with patients, carers, family members of those who had utilised the George Bryan unit, but also wanted to make sure that their local views were incorporated into the involvement activity that was then reviewed by the expert panels. So the transformation programme paused in March 2020, and we resumed the programme last year in summer 2021. This was supported by a sense check listening exercise in the autumn of 2021, and the outputs from that were collated into a report that the expert group reviewed in December 2021, and the decision was made in terms of putting forward the viable proposals. These proposals were put forward to the reference group in March of 2022, and the reference group included service users and other interested stakeholders. The information from this was incorporated into a report that was reviewed by the expert panel and incorporated into the development of the business case. The business case also includes more detailed analysis in terms of equality impact assessment and quality impact assessment, and this was reviewed by the Clinical Senate in June, and also by MPFT Trust Board, who reviewed the business case. We're now at the stage of sharing the proposals with you today, and we will be undertaking a review of the business case with the ICB later on in the month, prior to undertaking the assurance process with NHS England, which is their stage 2 assurance process. And a decision will be made in conjunction with the ICB for any potential public involvement, which will then be taken forward in terms of decision-making process leading us into next year. Next slide, please. So as I've mentioned, the business case includes further detailed analysis as well as the clinical model, and incorporated into that is the separate financial analysis of both proposals. The business case was reviewed by MPFT's internal governance, by the West Midlands Clinical Senate, and on the 30th of June, MPFT Board of Directors considered the business case and approved the process to move to ICB review and the next stages of the assurance process. As outlined earlier, this does not represent a decision to implement the proposal. Next slide, please. So as I've outlined, there are a number of steps that we need to undertake following on from today, and we want to ensure that we are working with you to shape any further involvement that we might need as we head into the autumn prior to making a decision-making business case. I'll now hand over to Paul Edmondson-Jones.
Thank you very much. Thank you everyone for that presentation. Can we go to the last slide, please? Thank you. Chair, I hope you and fellow councillors found that a useful presentation, both on the clinical case and also the process that's been followed. I just want to leave you with 3 points really before we open up to questions. The first is that key thing in this is that we provide quality, safe care supporting people to be independent for longer. And you heard a lot of that information from Lisa this morning, and Lisa and Abid will be able to provide more information if you want. The proposals must be viable, and Helen's outlined that in terms of legal process, we must bring forward proposals that are viable. We would be criticised if the proposals were not viable. However, we also need to be transparent, remain open to any new considerations come forward. And then the final one that I think we've emphasised before, a long way to go before we can make a final decision. We will continue to work with you and with other stakeholders and partners in this process as we move through the process. If I could hand back to you now, Chair, and invite any questions.
Thank you, Paul. Thank you also to Lisa, Steve and Helen. Thank you for that canter through where we've been through on the journey. Could you send us the slides and the video link as well?
Chair, I don't know about others, but I'm unable to hear.
Okay, let me just... Can anyone hear me at the moment online? Right, we've just got a technical hitch this end. I'll keep speaking and see if, because there's no point in me keeping quiet because you won't know whether you can hear me or not, will you? Can someone indicate if they can hear me online? Can you hear me at this moment?
There we go. I can hear you now, Chair.
There you go. Okay, I was just thanking you for the presentation and just asked if you could share with us a copy of the slides as well as the link through to the video, please.
Yeah, that's absolutely fine, Chair.
Thank you. And otherwise, I'm going to open up to questions from this side. I'm waiting to see... there you go. Janice.
Thank you very much, Chair, and thank you for that information, everybody. Just to bear with me to start off with, I think it's worthwhile just paying tribute to every respect of the hard-working and qualified staff, as was acknowledged earlier on. But also, I think it is worthwhile appreciating our role, representing residents, and especially some of the more potentially vulnerable residents within the county. And so some of the questions I have are establishing what has happened as to where we are now, and just looking at the evidence point, appreciating that we have had sight of 608 pages to try and ascertain some of that information. I have a less polite version of the introduction that the Chair gave at the beginning, but I will save that for another occasion. As far as the details that we can see, we got 76% rated the George Bryan Centre as good or very good, and then 42% as St George's as very good or good, and then 38% with regards to the community service. Now that was back in 21. I also picked up the note there about the potential public consultation that will follow. Is there anything that shows us that that's actually changed now? Because we're obviously moving away from what appears to be something that is working well as far as the recipients and the residents are reporting, as to what we're looking at proposing is my first question of many. Thank you.
Steve, can I ask that you and colleagues pick that up initially in terms of the satisfaction ratings?
Yes, of course, and thank you for raising that. Before I bring Lisa and Abid in, I think it's really important to make sure that when we do compare units to units in terms of what the questions are that we're asking, I think the other thing is you're quite right that this was in 21. So I think if we look back to 19 and then look forward to 21, obviously the unit itself is a much smaller unit, so that the population size of individuals consulted upon for the survey would have been different. So the 40% compared to the 70+% will be a determinant of that. So I just want to check, Lisa, Abid, is there anything that you want to raise with regard to that?
to my knowledge, I don't have the figures for 2022 yet.
Yeah, I mean, we can get that for councillors if that's something that's requested. So we'll put that down as a request. So thank you for the question.
Yeah, that would be helpful, please. Janice, do you want to follow up on that?
Yes, please, Chair. I'll just do a couple more and then obviously I'll give way to any colleagues as well. With review to workforce, and I'm also conscious, Chair, you say, but trying to do things thematically as well. So I'll also give way if any colleagues want to come in on the workforce side of things. Was there an issue at the George Bryant Centre prior to the fire taking place? It appears with the community-based model now that, in my mind, that's, say, peripatetic type of service delivery as well. And is that not something that may have worked in this instance if it was that we were to remain offering the same amount of service as what was done prior to the fire? So was there an issue with the workforce previously, because there appears to be now? And in terms of what we're doing with the community service model, is that not something that could be extended if it was to be the case here? Thank you.
Okay, thanks, Councillor. I'll try, Paul, if this is okay, to try and introduce an answer to this and then hand over again probably to Lisa in this first instance. I think we have something, Councillor, called safer staffing, and workforce in isolated buildings is sometimes quite difficult to manage. And so I think the short answer was, and has always been, yes, we've had some difficulties obtaining the right level of staff for the right level of support, and that you can see demonstrated through the business case, often escalated where patients need escalated by calling the police to that setting, rather than in other settings where there are more staff where we can support patients if things start to escalate in a way that doesn't involve other services, which of course is much better for those services and much better for the patients. So Lisa, can you give a quick answer to the detail associated with the staffing, because I know you live and breathe this every day.
Yeah, no. So I've overseen these services now for many years, and recruitment and retention at the George Bryant Centre was always a challenge because it was a small centre. It only offered a range of services and interventions. So there's a whole workforce development piece, I think, that I mentioned throughout the presentation. I think one of the things that we have done as part of our engagement is talk to the staff that worked at the George Bryant Centre prior to the fire, who are now either working at St George's Hospital or are have had the opportunity to develop into different roles within the community. And I don't think I've spoken to a single member of staff that would want to go back, because they feel so much more supported on a hospital side. As Steve said, the acuity shift in our patients that are coming into hospital is that they're often presenting with greater risk needs. It was two wards together. There was invariably only a couple of staff that could ever help out because of that issue. So I think it's been an issue throughout. Recruitment and retention into the NHS is not great at the moment, and I think we all know that and we all acknowledge it. There's huge pieces of work going on, but it was always an issue. I'm not really sure I understand the question about the peripatetic workforce, and I don't know if you want to just give a bit more detail about that. Was that the peripatetic workforce to support inpatients or the community?
Well, that was the point, really, was that it seems to me that is the approach on the community one, and if that would be something that would be appropriate if it was to be required, or if it could be at the staffing at George Bryant. But can I just pick up as well on one other point that you've just made, Chair, if that's okay? So you've just said about the safety of the staff. How does that apply when they're actually out in the community? And also, again, not wanting to bring in another topic again, is the work with the police. So we can appreciate that there were a number of calls there. Are those calls now happening in the community? So two parts to that. One is about the staff and how they're working out in there, and if they feel safe in the hospital. Do they not feel safe when they're out in the community? And if there's any evidence of that, please.
Lisa, do you want to pick that up, and then let's bring in Abid, who's waiting patiently.
Yes, of course, yeah. So in terms of staff safety in the community, that is not something that's presented a risk. They work in very big teams. In the community, we have 24/7 teams. So we've got a crisis home treatment team that works across the 24/7. We've got staff that actually work alongside the police. So staff safety in the community hasn't come up as an issue at all. Because the risk, if somebody was so risky, they would be in a hospital setting. I think that's the point. What we're saying is, because there is greater emphasis and enhanced community services, that actually less people need to be in hospital, but if they need to be, they will be. So I'm not, it's not come up as an issue at all for us. Abid, I don't know if you want to add to that, because I think you had your hand up for the earlier response as well.
I think what I wanted to highlight was that there were issues. It was a small standalone unit in the periphery of the trust. And because of the acuity of patients being admitted, they were being admitted to this site anyway because they were acutely disturbed. So they were being stabilized, and only once they were stabilized, they were being moved there. And there were issues in terms of if someone was acutely ill and they needed to be managed, we had to rely on police to help, which was really not a very desirable position. I think also there were issues. We had to have a separate on-call rota for that site, because that means that we need to provide 24/7 cover on that site. I think prior to the setting fire, it became like a pre-discharge facility rather than something that would take acute admissions. And what that means is that, by enhancing the community services, both in neighborhoods and localities, but also working closely with A&E department. So if a patient with mental health problem went to A&E department, our target is they will be assessed. Maximum time they'll have to wait is 4 hours. So we have 24/7 cover for Burton Hospital, for example. So we provided a lot of resource to enhance the crisis service so the needs of the population are met appropriately. And I think when there's a crisis, if there's a small group of staff, they can only do so much. Whereas on a bigger hospital site, we've got a lot more staff that can provide safe care of the patient. Thank you.
Thank you. Janice, are you done just for the moment? Can I bring in, Keith or Daniel, did either of you want to follow up on the subjects that Janice has been raising? Yeah, Keith, then you first.
Thank you, Chair. I picked up on the percentages in relation to how people saw services, the same as Janice has already told us. There was also some evidence that the community services that were being provided at the time were not considered by those users as well as those of the inpatient services at the George Bryant Centre. So I do think there's quite an uphill struggle here for people to be able to get more confidence in what's being proposed. If we are going to be going into the community and offering these services, I think that's something that this committee should get very heavily involved in, as we, as members of our communities, will be representing those people, not so much myself, but certainly those in the south of the area, of the whole county. And so therefore, I would like to see how they are going to improve people's perception of those community services. I think that's going to be a very important element if they are going to go down this line. I don't think any of us are going to argue in terms of medical reason or structure or anything else, that with the idea of physical services and everything else all being centred at one location, I don't think we can argue that case. We're not experts, and therefore I don't think we can argue the case in that bit. But it's this other model of how we're going to present these services, particularly in mind that the majority of people using these services on one of the data maps that which is in the pack, for me anyway, did look like the services were mostly used in Tamworth. across that particular area. And I do think that, again, that's another question. How are these people going to travel? I know that's been brought up in some of the later data in the paperwork and everything else. If people can't access it and you're going to rely on the community provision far more, then again, that's another reason why we need to understand how these community services are going to improve the lot of the potential patients in the future, or rather keeping them out of hospital. That will be the case of this. So I do think there's a lot more to answer on that. I don't know whether the chair could pick that up as something that we can look at as time goes on. But I'll stop it there, because I think that was just something I picked up from Janice, the idea of using and people's idea of how good those services are at the moment. Thank you.
Lisa, is that one for you?
Yeah, I'm happy to answer. I think it might be helpful if Nikki also comes in as our strategic commissioner, if that's okay, Chair. But I think I don't disagree with the point that's made. The community services that we've been developing are an evolving model. So the comparison pre the fire to now is very different, and I think you're right, we need to do a lot more engagement around that model and how it's working for people, and I know that's part of the evaluation piece that I'm hoping Nikki's going to come in and talk to you about now.
Yes, thank you, Lisa. So the community mental health transformation, we're in year 2 of what is a national sort of mandated transformation, and obviously we've been working really closely with our service users, carers and families as to what that actually means for our residents in Staffordshire and Stoke-on-Trent. So there is very clear additional investment coming in to support community mental health transformation, and that is focused on people with severe mental illness, and that's alongside a number of other developments. So it's looking at the entire model of mental health care from our sort of early access points, so putting additional mental health practitioners into primary care, into GP surgeries, linking them in with our what's called our IAPT, our improving access to psychological therapies provision, right through to our community mental health transformation and the other developments that Dr. Abercarn's talked about in terms of having core 24/7 psych liaison support at Burton's Hospital, to the community triage provision that we have in place that's a specialist between MPFT and the police. So there's lots of different elements and building blocks of our community mental health provision that we're working to kind of develop that really cohesive model that makes our services as easy to access for all of our residents as possible. And I think that's where you're sort of alluding to. We are also obviously testing some of these models out, but more importantly, we're evaluating and learning from all of this. So we have a programme in place to look at, what is actually meaningful care for service users and families, and what are we delivering that makes the biggest impact for them in terms of their recovery. So that's part of the work that we'll do as a collective as we move forward. So I think Jenny wanted to come in on that.
Yes, I think it was just in terms of the reach of the engagement activity and the figures in terms of people's perceptions of the services. And I think that does provide us with some insight and some wealth of information that we need to look into. But I think also it's a much bigger picture than those figures perhaps present. So the engagement activity we went out with was very targeted and specific to experiences of the George Bryan Centre, and I think if we were to look at feedback as a whole for the St George's Centre, we would probably want to go to a much wider population that also includes the likes of Stafford and Cannock and other surrounding areas. So I think it's just a note of caution around those figures. They are useful and they do give us that intelligence, but I think in terms of that wider perspective on St George's, then I think we would want to go to a much larger part of the population, and I think we'd also want to look at other factors such as patient satisfaction surveys, etc., that I know MPFT do on a regular basis.
Thank you. Just before I bring Keith back in, what about the secondary part of his question, which related to travel and accessibility?
Steve, do you want to take that one?
Yeah, thank you, and thank you, Chair. It is a really important point, and it's something that we are very conscious of. One of the things that we are starting to do, and I think Lisa had alluded to this, and the council has given really good insight into the importance of the community offer that supports people that can be cared for in the community, rather than those people that become acutely unwell that sadly do need to stay with us for a hopefully small amount of time. However, when they do stay with us for a small amount of time, we need to make sure that their loved ones can visit or have access to them digitally if they don't want to visit because of whether that be pandemic issues or whether that be travel issues, or indeed sometimes that might be timing if people have time restraints. So there are offers that we've put into the business case around digital solutions, which will include conversations like this, which happened during and over the pandemic as well. They proved to work very well for people who didn't want to travel into a hospital setting, but still wanted to stay in touch with loved ones, which was really important. For the very real issue of those people that would require support to travel, albeit hopefully for a small amount of time, then that would be supported by the Trust through its support to patients, irrespective of their particular state of residence, if they stay with us in any one of our inpatient settings. And we have a policy for that, Chair, which supports carers and patients for that travel that would be supported either through alternative routes by working with our voluntary sector agencies and our supporting agencies, or using some form of transport that would be reimbursable by the Trust through our policy. I started our conversation by saying we wanted nobody to be disadvantaged, and in recognising the better quality of care that we could offer and the safer response to care that should or could be escalated by a patient's needs if, as Dr. Khan had said, they are acutely unwell, if they stay with us, then actually we want to make sure that anybody that visits them or anybody that would like to speak to them can do that in a variety of different ways, which I think we proved over the pandemic to be very effective, and we'll continue to get feedback on that and work with the population. But we can do that physically, Chair, as well as digitally, and of course the old-fashioned telephone always works if the patient is able to speak. So hopefully that gives you a quick answer.
Keith.
Thank you, Chair. Yeah, I'm still concerned, as I say. I don't think we've got enough evidence here. I know we've got some investment coming in through the health services all. I think it was 5 million and then up to 6 million in 2023-24. I would like to see something working far further into the future, so to have some aims and objectives that we can look at, because I'm still concerned that this new approach, which is relatively new, I know that we've been looking at it from other things as well, in terms of our strength of our communities, and certainly many of us have been putting loads of time into looking at ways that we can link up many of the different groups within our different divisions and everything else. I do think this fits quite well into that. But I do think that to get it out to the general public, to get this information out there, and to get this so people can understand it without being frightened of it, I think that's the key element that I think I would like to take from today's meeting. Because if we are going to have, I mean, let's face it. You've presented us today that there's 2 options and no decision's been made. The picture I get actually is that clinically there is no other option. There's only one option on the board at the moment, and I think that the rest of us can see that coming. I mean, if you look at this to some extent, you wonder why the George Bryant Centre was ever built by the, and used with regard to the output of these assessments. But nevertheless, I think we've got to be positive and try and look at ways forward. So I hope, Chair, that we can take this forward. That money doesn't sound a lot to me, to be able to rearrange the entire perspective or idea of how people are looked at when they have a mental health issue within the south of Staffordshire, well, across the whole of Staffordshire by zone. And so my last question is that money for just this one area, or is that money for services across the whole of Staffordshire and Stoke? If it's the latter, then I would suggest that it's nowhere near sufficient to be able to change and to alter the services that are out there at the moment. Thank you, Chair.
Steve, is that one you're picking up?
Yes, and if I could say to the good councillor, absolutely agree, thank you. The more money that gets invested into mental health, the better the service offer can be. So absolute thank you for that one. In relation to the money that we're talking about here, we have a community transformation piece of work, which Lisa has alluded to, but we also have a mental health investment fund, which is coming down from government, that will start to look at reinvesting in mental health and start to bolster services. Now, as a provider that covers multiple areas, 2 things that we need to be clear on. One is that our job is to make sure that nobody's disadvantaged, irrelevant of geography, and we're able to support people across many communities and many of our wards and boroughs. But more importantly, we have a safe and high quality offer, which, as the good councillor reminds us, will require a significant amount of resource. So I'm really conscious, Chair, that I'm with my commissioning colleagues at the moment. So I'd like to say to the councillor, if there's any sort of support you can give the provider to convince the commissioners for greater investment, then please do so. But Nikki, I think you'd like to come in because you've been a brilliant advocate of mental health as a commissioner. So thank you.
Thank you, Steve, and thank you, Councillor. So to answer the specific point around that 6.2 by 23-24, that is across the whole of Staffordshire and Stoke-on-Trent, but that is specific to community mental health transformation. So that's one kind of programme of a whole number of programmes that as the ICB we invest in to ensure that we can meet the needs of our population. As Steve has quite rightly described, we have what's called the Mental Health Investment Standard, and that basically protects the investment for children and young people with mental health illness and adults and older adults with mental illness. And the expectation is that the ICB increases that investment year on year. So we have a range of deliverables to meet. And as I said, it's important to think about, as you rightly understand, Councillor, there's lots of other provision out there alongside the community mental health transformation, and it's how we kind of bring all of those together. So it's things like our investment in our voluntary sector community partners, it's our investment within primary care, it's the way that we work with our social care partners is incredibly important, and the way that we work with our wider community to build sort of resilience around good mental health and make sure that those experiencing poor mental health have the earliest opportunity to access possible. So that's the way that we're kind of delivering, but the ICB is committed to ensure investment within mental health across the area.
Thank you. I said we would try and be thematic, so I'm just going to jump in before I bring in Daniel on just 2 points which may be useful. First of all, relating to travel options. You mention within the paper that there are travel options. We've talked about how important accessibility of services is. I don't think it's acceptable to handle that on a case-by-case basis. In my view, there needs to be a clear, transparent policy that people can see, and then you can deal with by exception if there are some people who fall outside of the policy for hardship reasons. But I think there really does need to be a transparent case, because otherwise, how does a resident know whether they fall into or outside of that policy? That's the first point I'd make just on transport. And the second point I'd make is you very kindly gave us reams of contracts to read, which I thoroughly enjoyed poring over. But many of those dates of those contracts terminate in March 23, and I think that would be very useful to pick up the previous points relating to community services, and the move towards community services, to have a greater commitment than what effectively will be the timeline of taking this decision. And bearing in mind it takes years to build hospitals, or any building actually, I think that a greater commitment in terms of timeline is required. Otherwise you remove one set of services without a clarity that there is another set of services there. Could you just very briefly answer those 2 points, because I think they're relevant? I don't know.
Steve, do you want to pick the first one up, Steve, on the transport case?
Yes, thank you. And Chair, in short, yes, thank you, yes. Will be a very clear and a very understandable policy that we'll have. We already have one which is currently being reviewed to make sure that we take this into consideration. So a policy is one thing, but as you will also appreciate, and forgive me for my flippancy here, some of the technical documentation that we as public sector bodies have to produce end up with you having 600 odd pages worth of information to review. What we'll also make sure is that policy is fully understandable, but we will produce a more accessible version for those people so that it is really clear on how you get the options that are most suitable for you. So in terms of the policy, the short answer to that is yes, but we'll also commit to engaging in a more meaningful, accessible way, including use of the website and literature and documentation for the population.
Thank you. And Nikki, is it appropriate for you to take the second one on contracts?
Yes, absolutely. So the reason for those contract dates is not because because we intend to cease to commission. It's about how we change our commissioning model. So what we want to do is obviously with some of those contracts is what we're doing is we're really testing how we work with providers, a different set of providers, to get that very specialist input into for our service users and families. So where it's housing, for example, that we're really working with the specialists that know the detail around that and can support our service users and families effectively. Where it's things like finance, where, for example, we've commissioned the Citizens Advice Bureau, that they're the best specialists to be able to provide that expert advice to make sure that we're maximising the income for our families so that they have a good basis on which to kind of recover. So that's the contract dates, or with the premise that we will enter a different type of commissioning, a more collaborative level of commissioning, whereby we're more kind of even more joined up, if you like, in terms of understanding.
You've gone on to mute, Nikki.
I beg your pardon. Sorry, I beg your pardon. So it's really about understanding the value of each of those partners, what they're able to bring to support the recovery of our service users and families, and how we kind of can move to that more collaborative way of commissioning where they have a real sort of stake in that partnership and are able to do some of the really innovative things that we know our small voluntary community sector providers can do. So it's not with the intention that those contracts end, it's with the intention that we do something even more transformative in terms of our aspirations for how we meet our population's needs moving forward.
Yeah, I understand the points you've made. Thanks, Nicola. Maybe the way around this one is to make sure there is a clear commitment in terms of community services as a principle, rather than to very specific providers. I'm not asking you to do that. I think there is need to demonstrate that you are committed to the model so that there is clarity. Yes. Let me bring in Daniel. Daniel.
Thanks, Chair. Just 2 points. Firstly, I'll go on to the travel. Obviously, I said at the start, interest, I'm from Tamworth. If somebody finishes work at 7 o'clock, sorry, not 7, 5 o'clock, and gets a bus at 5:30 to St George's, that family member then can't get back to Tamworth after visiting their family member in hospital. So I was at the board meeting a couple of weeks ago, and you said that this has already been happening through COVID, that you've had families transport, whether that's been put on, I think the suggestion was taxis or private sector. Is it possible to have some data of that? Because it's one thing to say that it's happening, but we need to see that it's happening. Because as mentioned earlier, I was in George Bryan, and one of the main factors of me getting out of there sooner was my family being able to visit me. And if I then had to have gone to St George's 3-4 weeks added on to my stay. Second point about, just go back a bit further about the safety, about the community and safety. I've got an example of that happened a few days ago, where I had an appointment the next day, but I had, we'll call it a mini crisis the day before. And my appointment was cancelled on safety grounds. So my appointment with a clinician was cancelled because you guys couldn't secure your safety, which I've then had to wait 3 weeks for another appointment, which I think is a bit backwards, because surely I could have done with that appointment then, where I've then had to wait because of safety grounds. So I think that's a bit wrong to say that it hasn't happened, because it has. And that's not just from my point of view. Other people in Tamworth have said that to me as well, that they've had appointments cancelled because the clinician can't come out on their own. So just like a bit of feedback on that, please.
Okay, thank you, Councillor. Steve, I wonder if you could pick up the first one on the travel issue, and then maybe Lisa and or Abid could pick up the second one on the safety.
Yeah, thank you. And again, thank you, Councillor, for your questions. I know you asked some questions at the board, which was also really, really helpful. And it goes without saying, but thank you also for your commitment to supporting mental health. I think with regard to the data and the usage, yes, in short, we'll have a look at producing some of that for your good selves. That might be difficult over the pandemic because it will have been clouded with a whole raft of other patient transport issues that we put in place, including the use of virtual technology, etc. But Chair, we'll do our best to try and produce some information over that period of time for patients that will have sought out travel from what would have been the George Bryan to St George's, and we'll try and produce that for you.
Thank you.
On the individual issue, Daniel, that you raised about safety, it's really difficult to comment on individual cases without knowing the details. So if you want to have a conversation with me afterwards, I'm happy to look at what happened and provide you with an appropriate response, because without knowing the detail, it's hard to comment. I don't know if you want to say anything, Abid.
I was going to say, Lisa, I'm happy with that as a principle, to take it outside of this discussion. I think Daniel was trying to talk about the general point, but it's very difficult, you know. There's a lot of pages. I read 609 pages or 608 pages. I don't remember many stats in those in terms of performance stats and things like that. You know, the number of readmissions, all of those bits and pieces which would have built your business case. And I think in some ways, Daniel's probably referring to some of that. Let me just, Abid, do you want to come in, or shall we just go back to Daniel?
I think I was just going to make a general comment, really. If an individual is disturbed, if a patient is disturbed and they feel that more than one staff member need to visit, then they probably would agree a time and reason for that. So I would think that, you know, to be open and have a discussion with the patient rather than unilaterally cancel appointments.
I'm happy with that, Daniel. Are you happy with that as a...
Yeah, it was just a bit more on the broad, not specifically about me, but just to point out that these things are happening. And I think the comment earlier was there have been no safety concerns, but these things are happening.
Okay, I'll let you go into that with more detail with Lisa. Can I just follow up Daniel's first point, which was on transport? I think it'd be really, I was very concerned reading the papers that there were people who were needing to take 3 buses, and just the sheer volume of space and time that must take. Maybe you could do a map, because I didn't think the transport data was particularly robust or effective. Didn't really, as a logistician, you didn't really tell me very much. And the reality is, if you'd looked at the modes of transport, whether it was buses or trains, and said how easy it was for people to get to visiting and get back home again, I think that would have been a very useful exercise, because fun enough, you are talking about some very deeply rural areas, and if you look at where people are coming from, which includes Utoxeter, in terms of some of those users of services, I was quite surprised at where they were coming from and actually the level of impact. Let me bring in Jill Hood.
Thank you, Chairman. I have 2 concerns, having read the report. One was particularly on transport. In my division, I work in a volunteer capacity, 2 organisations who both run volunteer community transport for hospital appointments. And since the pandemic, one organisation has gone down from 284 to 6 volunteers. The other organisation has gone from 112 to 4 volunteers. We've lost all of our volunteers. And I find it alarming that quite often, we've heard this morning, proposed reliance on community volunteer groups. And in my opinion, this just isn't going to happen. It's that it's shifted. The goodwill, the enthusiasm for volunteering has almost gone now that the probably the pandemic has washed away. The second thing that goes along with community volunteering is that in my division we have a lot of residents travelling to Cannock Hospital, many of them vulnerable and elderly. It's 4 bus journeys, and even then they're not guaranteed that they're going to get home at a decent time at night. So the idea of people travelling from all over Staffordshire to get to Stafford, that there's got to be a lot more thought put into that. We're talking about the number of staff that need recruiting, which look very, very impressive. Crisis teams, nursing therapy lead, clinical psychologists. Before we heard about your business proposal, before we read this, we're all aware of the shortage of staff working in the NHS. There's no mention of how many vacancies you've got, just a few mentions of how many you've got to fill. How on earth are you going to do this when we know that it's nationwide? It's not just here in Staffordshire. I would like some feedback on that, please. Thank you, Chairman.
Thank you, Chair. I think probably the first question in terms of the transport, Steve, I think we agreed that we would take forward and look at what we could do in terms of mapping across the county and so on. And I think we could probably look at that, couldn't we, in terms of the mapping from different areas and what that does. If I could go to Lisa first to pick up on the workforce issue and the recruitment issue, and then I wonder if one of the my commissioning colleagues wants to comment on the voluntary community services. So Lisa, could we go to you first?
Yeah, no problem, Paul. Thanks, and thanks, Jill, for your questions. Very, very well made. And I think you're right. Workforce, it is a challenge for the NHS. The posts that you referred to in your introduction to the question are actually already recruited to. So those were posts that were recruited to at the when the decision was taken to temporarily close the George Bryan Centre. The biggest part of recruitment that we have in place within MPFT to support the transformation is around the community model. So we've got posts that we are recruiting to, which are new posts. There's lots of new posts that have come out as part of the NHS plan to support the development of the workforce. And, you know, I would be lying if I said it was easy to recruit, because it actually is a challenge at the moment. The NHS doesn't receive a lot of good press right now, which I think is really impacting on recruitment. But what we are doing is looking at how we can develop workforce strategies to support people, not only from the apprenticeship model, but right through to qualification. And I think that's the focus that we've been taking. I can get you some data on vacancies and we'll drill that down for you for mental health services, because obviously MPFT data will be about the whole organisation, which is much bigger than mental health services. So I'm very happy to share that data for South Staffordshire mental health services with the group.
Lovely, thank you. Nikki, do you want to come in on the question of the voluntary and community sector?
Yes, yes, and thanks, Councillor, for the question. So when we talk about our sort of voluntary community sector partners, it is just to be clear that we are resourcing them. So they are being formally commissioned to deliver. So they are being, you know, paid to be part of that provision. But I absolutely take your point that, again, the shift in the pandemic has changed people's volunteering opportunities and how they wish to do that. And I think it goes back to the point again one of the councillors has made about how do we get this message out here about our mental health services and we make that more visible, and actually how do we start to make sort of mental health an attractive place to be part of the workforce, whether that's in the formal qualifications that, you know, the workforce that Lisa's talked about, or whether that's in the really valuable workforce that is that volunteering time and community time that lots of communities give. But it's just to sort of clarify that point for you. Thank you.
Jill, do you want to come back? No. Okay, let me bring in Phil.
Thank you, Chairman. Sorry, my question may seem a tad rambling. There's nothing new there. You probably give some thoughts to. Firstly, just a comment. I have every sympathy with the transport issues, and it genuinely is. But the one question I would ask over and above that is when we look at heart conditions and cancer conditions and stuff, then we tend to centralise the expertise. And I know within, you know, it's like a lot of family members. I have a family member who experienced quite serious cancer issues, and centralising that really worked. It meant us going to Stoke-on-Trent, and so that in itself was a challenge. But what overrode that was seeing what was the very best oncologist. So if we're going to cause the kind of challenges, or if the kind of challenges are going to be caused by the transport issues, and I have every sympathy, by the way, with what's already been said, but that, would that be overridden by the level of expertise congregating in one hospital? So that's a fairly simple question. I still would like to see the transport problem solved, by the way, and recently a friend told me where they had health issues and got sent off, mental health issues and got sent off to Leeds, and you know, how is that appropriate? It's not appropriate at all. The second thing is, we talk, and I'm reading the notes, and you are right, Mr. Chairman, there was a fair amount of reading there, wasn't there? So it talks about enhancing the care plans, making things better, and that's absolutely fantastic, because if I was just going from my experience, by the way, I have no mental health issues personally or within my family, I'm pleased to say at this stage. But what you do read in the press, and what I have two friends and family that work in the mental health sort of system or for the NHS, and they tell me it's just one big crisis. The reality is that it doesn't work. The people don't get into hospital. The people don't get seen to. And what Daniel made the point about it being deferred by 3 weeks. So I listened to the presentation, and thank you so much for the detail. Thank you for all that. And it felt like, whoa, we nearly perfect, and as soon as we open St George's, we will be perfect. And excuse me being a tad sarcastic. But it doesn't feel like that, Mr. Chairman. It feels like our mental health service is in crisis. So amongst that statement, I'm going to give a question. So if we do all this, and if we choose one of the things, are we going to measure that? And are we going to have people back to say, actually, you know, we spoke to you back in August. It is August, isn't it? Yeah. We spoke to you back in August. And it's now sort of January, February next year, or August next year, and look how things have improved. We've had some challenges, but look how things have improved. And clear measurements, because I pick up on your point, Mr. Chairman, I see no clear measurements. What I see is, you know, the press sort of very upset, staff upset, and all sorts of people upset about our care thing being in crisis. So there are some questions in there, Mr. Chairman, somewhere. And can you indulge me with one more, please? Are we working closely, or have we got a good relationship with social services and with social care? So if social services pick something up, because as councillors, people ring us up for, you know, all sorts of stuff, don't they? And one woman rang me up recently to say she couldn't feed a dog. You know, and that's actually not funny, because she couldn't feed herself either. So you get in touch with social care, and it was fairly obvious there was a mental health crisis going on there. And the question is, how joined up are we? Is that working? It was easy for me to be joined up, because I just ring social care and say, is this person okay? And see if anybody's concerned about the dog and the woman. We immediately took some dog food over and some food for her. So that was easy for us. But the long term, there's some serious challenges in there. So, you know, how good is the tie-up between social care and our social services with the mental health system, that when social services see an issue, then they can interrupt the mental health NHS and say, this is it. Mr. Chairman, as always, I went on far too long, but I hope there were some sort of relevant questions in there.
So I think there were 4 in there in total. There was a Centre of Excellence question about St George's, the crisis within the system in terms of being seen and the volumes of people being seen. Thirdly, what the measures of success are, and fourthly, the relationship with social care. So Lisa, are you picking up the Centre of Excellence?
Happy to, and I'm sure Abid will as well. But in short, in answer to your question, it's yes. St George's is seen as a centre of excellence. We got great feedback when the West Midlands Clinical Senate came. I think that was about a month ago now, wasn't it? Around the types of services and the interventions we offer. We offer a whole range of different interventions, but also services on that site that enables us to be able to deliver specialist mental health care, because that's what it is. Abid, I don't know if you want to answer that as well.
I would like to say really that please, mental health services are provided in the community. Hospital is a small part of it. So patient journey goes through the hospital, but they carry on their lives in the communities. So our challenge is to train people in the community. And I can assure you that most of our trainees are not based in the hospital, they're based in the communities. So they are with the consultants providing community services out there. They are getting training both at junior doctor level and at senior registrar level, which means that we are growing number of consultants. New services that we established, liaison service is one of them in acute hospitals. We have got training provisions in them. So we are trying to train people not just to look after patients when they're admitted to hospital, but a vast majority of them are training to look after people in their own home, visit teams with the crisis team, for example, or the community mental health team, or work with GPs. The second point I would like to make is that we have, during COVID, there is a forecast that the mental health demand has increased. So to address that demand, NHS England has released more training posts. And I can assure the committee that we have made sure that we get not just our share, but a bit more, so we can get more doctors. We are not just focusing on training on doctors, but all professionals like physician assistants or pharmacists in the community. So I think we are taking every opportunity we can to expand the services so that we can meet the need of our population better. Thank you.
I think the second question was about the crisis in mental health services, which I'm happy to start to give a commentary on. I wouldn't describe it as a crisis. I think the NHS is under significant challenges, we all know, but one of the positives from a mental health service perspective, which is very different to what our acute hospital colleagues, primary care, and some of our physical health community colleagues experienced, is we didn't stand services down. So we were expected to continue to deliver mental health services throughout the pandemic. What we were asked to do was to think about whether we could deliver them differently, use much more digital technology, which I alluded to in the presentation, that probably would have taken us about 25 years to implement if we hadn't have been in a pandemic, but we did that at pace, which enabled people to have access still, because a lot of service users and patients opted to contact us through a virtual process. So I wouldn't describe it as in crisis, but I would say that it's incredibly busy. But from my perspective, having worked in mental health services for 30 plus years, this is the first time that we've ever had ring-fenced investment for core community mental health services that can only be spent on strengthening core community mental health services, and the Integrated Care Board have really supported that. So I feel really positive that the funding is going to where we need it to go to. And as Nikki alluded to, the mental health investment standard, that we have to provide assurance up to the national team that that is being spent on mental health services. So whilst, yes, it's incredibly busy, yes, we're seeing people that are really quite acutely unwell, that probably have been impacted by the pandemic, and particularly social isolation and some of those factors. but actually we've got dedicated investment, so it gives us a real opportunity to strengthen our services, but also think about how we work differently. I'm going to let Abid come in before I answer the social care one, because I think it might be on this issue rather than social care.
I just wanted to support Lisa in her assertion that mental health services are not in crisis. That is absolutely true. We meet people's needs depending on their clinical acuity. And if a clinical situation demands that they are seen quickly, they are seen quickly. I get the bed state of the hospital every day, and we are always in a position to help, work together. We work in collaboration, and if we can't if we don't have a bed, we make sure that the patient is admitted very quickly, either to us in our own bed or in one of our partners' beds. So please, the notion that mental health services are in crisis is not correct. Thank you.
And the last question was about social care. So from a South Staffordshire perspective, within Midlands Partnership Trust, we've had a partnership agreement with Staffordshire County Council for about 10 years now, and that was predominantly for social care around mental health services. When we integrated with Staffordshire and Stoke-on-Trent Partnership Trust, we took on the partnership arrangement with Staffordshire County Council for social care around older people's and physical disabilities. So what we provide are integrated health and social care teams to the population of Staffordshire. We're able to work together and deploy resource. We share caseloads, we case manage together. So I feel we're in a really great position with social care in terms of our ability to work together. And again, I think, Nikki, you want to add to that.
Yes, I would just support what Lisa has said, and obviously we know that social care influence goes wider than just the social care workforce that's in place as well. So it's really important as to how we continue to work with our local authority colleagues in both Staffordshire County Council and obviously the district and borough councils to make sure that we are doing the best, absolute best for our sort of residents and patients. Just one of your other questions, I think, was on sort of impact measurement of the programme. So one of the, obviously we always sort of seek service user and carer feedback continuously, and we gather that, and we always use that to inform and make any sort of improvements or learning. But one of the things that we've specifically done as part of the community mental health transformation is to set up an evaluation outcomes and performance quality group that actually the ICB, so I actually lead that group directly, and that really is about looking at how this model will improve access, improve outcomes for service users, improve experience of service users, and actually ensure that patients and families are getting the care and the impactful care that they need. And I think one of the things that we need to do, and we need to do, we can do more of this, is really look at sort of real-time outcome data and processes and how we use those to improve services. So that's certainly something that we're looking to build on as part of the programme as well.
Thank you. Phil, do you want to come back?
No, Chairman, I'm fine with the answers. I still would like to put a further date in and keep this one sort of on the boil, Chairman, and invite them back at some stage. I accept they're very busy clinicians, so I have to accept that, but I'd still like this one to go well beyond this meeting, Mr. Chairman.
Thank you. Nicola, can I just come back in the absence of Phil doing so? The measures of success, I think they are broader than just patient and how patients feel. You know, I think there's a whole range of them, which is, you know, what is the speed from referral to being first seen? What's the speed from referral to being treated? And you know, we can think of a whole range of them. And there's none of those commitments in this business case at all. And I think the business case is all the worse for that gap. And I think that Phil's question is exactly right. We should see what is the commitment by making these service changes that you are, as a provider or as an ICB, proposing for our residents, our joint residents. Steve, I notice you might want to come back in.
Yeah, thank you, Chair. And I think just to say thank you to the Councillor for realising and recognising the challenges that we're under, albeit probably, I think, as Dr. Khan and Lisa had said, not in crisis, but it's still difficult. I think is probably the wisest way to couch this. But also, Chair, the recognition of what we would class as more type of specialist or acute care for mental health in terms of an inpatient facility, which of course is different to community. And so I think the reference across to cancer and heart services there is a very well made statement. And although we would never say we should compromise, what we should say is that it does provide benefits, Chair, and this is the point I was going to make around the measurements. On behalf of the Board of Directors for MPFT, and one of the things that we will want to see is that whatever decision is made with the future of these services, there are direct demonstrable benefits to patient care, and they translate themselves into what we would class as some of the transactional targets. So some of the things like less police calls, escalation of care, etc., and some of the less tangible targets around feelings, emotions, and engagement with the services. So with your agreement, Chair, I think we would want to see that as a board anyway, and we can discuss that with our ICB colleagues in terms of what that looks like and what we would see as a benefits appraisal following the business case, which should strengthen the question that you've answered and hopefully provide us with the opportunity to objectively bring you something back.
I think we would all welcome that, and that's very helpful. Thank you, Steve. Let me bring in Daniel.
Thank you, Chair. Just wanted to come back on the community care and how that's been bolstered up. Tamworth's had Midlands Partnership Foundation Trust in the form of Upcar Singh coming in to give us talks about the transformation programme that's been happening. I think it's brilliant if the evidence is there and it is improving care. One thing has been said previously, it looks like although the decision hasn't been made, there is only one proposal on the table. But at the minute, mental health appointments in Tamworth are being conducted out of a sexual health clinic. Would George Bryant being rebuilt as a community hub not be a viable option? Also, expanding a bit on that, at the board meeting I did question about the insurance monies, which was said that it was invested.
Sorry, I'm not sure if the insurance money is a relevant issue for us as a health committee. Just tell me where your thinking is going before we go down a blind alley.
Just that I was told that the money had gone to staff that had gone to St George's. I just wanted to know that if any of that had gone into bolstering the community area as well. Okay.
Maybe someone can give a one sentence answer to that second point. I don't really want to follow the money here. I really want to follow the services and the outcomes for patients if we can. But there were 2 points there.
One last one, Chair. Sorry. Just about the involvement. I took part in an event in October, and from the date map that you showed in your presentations, there was about another 3 or 4 events after that. I mentioned this at the board meeting the other week and was told that emails had been sent out, everybody knew about the events. I went back through the involvement emails. Not one email had been sent to me about these events. Just wondering why that was. Thank you.
Okay.
Steve, do you want to pick up the one on the insurance money? And then maybe Jenny, could you pick up the one on the involvement?
Yeah, sure. Thank you. And again, thanks, Councillor Chair, and forgive me for being process and detail orientated. I'm very conscious that the conversation that we're having is around the clinical model associated with our inpatient services, and therefore wouldn't want to prejudge a conversation about any of the bricks and mortar associated with what we're about to do. However, the council makes a very good point about the fact that the community service offer that we currently have at the moment is in a temporary situation as temporary build, which is not fit for purpose and something that the trust is committed to moving, because again, the proximity of that to the town centre, the localisation of workers being able to travel in, travel back out is something that we're taking very seriously. The investment side of that, councillor, for the insurance money was around £1 million, and it came in a form of money that was very difficult for us to know. It was revenue, not capital, and hopefully I've got that correct. However, a lot of that's been reinvested in our service offer, which will include our community offer. But that won't be by far enough for us to support the community service offer that we're going through. Hence the team through Upcar and Upcar and Lisa and Abid are making sure that all of our community service offer in that part of the world is being reviewed and strengthened. But at this stage, Chair, I wouldn't like to comment on the building. I'd rather focus us back on the inpatient, if that's okay with your good self.
Yeah. Shall we, Jenny, do you want to pick up the involvement? And then I think Helen wants to come in as well on that, please.
Yeah, happy to do that. So I think there's two key events that have happened within that timeline. So obviously there was the activity in October, which was a wider public listening exercise, and we held a number of events, and there was a survey. And that helped to shape the proposals that the technical group of those experts and clinicians and Health Watch looked at in December 2021. So the only other event that I think that you're referring to is the reference group that we held in March 2022. And that was quite a small targeted group. It wasn't a wide public meeting. And the reason for that was there was a lot of detail to be shared, very similar to this morning's meeting. There was pre-reading involved. And so that smaller reference group, which was targeted, including service users and interested groups and people, they went through that detail, had those clinical presentations, and then looked at, are there any other considerations that we need to take into consideration, and is there any other impact that we need to be aware of and to try and mitigate against. So my apologies if you didn't receive information about that event in March 2022. I will go away and have a look at that, because you're clearly a very interested a councillor, member of the public on this issue. But in terms of that March activity, it was a reference group. It wasn't a wider public listening exercise, if that makes sense. But I'm happy to take any other comments or questions.
Dan, do you want to come back?
Thanks, Chair. Just one more. Could the events in October have been more inclusive? Because I understand about the pandemic, and we did go through another wave leading up to that. But it was just online and an online survey. When at the meeting in August last year, it was promised that some of those engagement events would be face-to-face, where people could be in person. Thank you.
Jenny, is that with you?
Yeah, I can answer that one. So I think our priority had to be the safety of people taking part in those listening events during COVID-19. Sadly, that was why it did have to be digitally focused in terms of the events and the survey. But we did have a phone number and people ready to be able to support people to answer that survey if they wanted to, and they couldn't have access to those digital tools. We also approached a large number of voluntary sector organisations and different groups that support people with mental health needs, and again encourage them to take part and ask them if they needed any support, or if their networks needed any support to take part. So we did try to make them as accessible as we could. And the other thing I would add is we've done these involvement sessions, these listening exercise, but as colleagues have mentioned before, we never stop listening. So at the moment, we are still working with voluntary sector organisations. We are still seeking to get into some of those communities that perhaps haven't been as vocal or haven't participated so far, and we are trying to get that feedback from them. So even now we are still working with voluntary sector organisations, Health Watch, to try and seek feedback from groups. And any of this will obviously be considered by the ICB, and we want to work with the committee to look at whether any further potential involvement activity is needed in the autumn.
Daniel?
Thank you. I think the only thing that I would add is that as a service user, I have not been approached about any of these involvement sessions. Only as a councillor have I been able to have input into these sessions. Cheers.
Thanks. We'll just take that as noted, and maybe that's just something in terms of your future communication. I think we've talked about patient pathways, and I think in some ways this is linked to that in terms of how that engagement should go going forwards, notwithstanding the difficulties provided by COVID. I did want to pick up 2 or 3 points, if I could, just to sort of go in some different directions. First of all, I'm surprised that the insurance money was £1 million when the rebuild cost of like-for-like is close on 8 million quid. That did surprise me as a piece of information. Second of all, and I think it's fair for MPFT in their business case to say, do you know what, we shouldn't really be discussing the future use of the building. I accept that from MPFT's point of view. But I think the commissioners need to be really clear what the health service proposals are for residents of Tamworth. Because if I was a resident of Tamworth, or Lichfield, who are also big users of these services, and East Staffs, I'd be saying, well, you've taken away something that I had. Okay, you've added in community services and reduced the need for the George Bryan Centre, but effectively, there is a reduction in things that were there and accessible. And we've talked about the accessibility point. And actually, I would have much preferred to have seen as part of the proposals for health services for residents in the south of the county, southeast of the county, for there to be very clear views as to what we're going to use this building for. Otherwise, frankly, it's going to sit there and, someone will eventually say, well, it's not needed. Well, actually, how do you know as a commissioner that it's not needed for something if no one is going to look at that as an issue? So I actually think that Daniel hits on a really important point, and whether it's for community services or whether it's for CAMS or whether it's for something else, I think that's it's a really good point. Daniel didn't touch on this, but there is another point which I think is completely missed by only having one viable option, and that is, quite rightly, in my view, you've closed on safety grounds the east wing. But there is no modelling at all and no discussion in the paper at all of what happens if you expanded the services from the west wing, which is rebuilt, and to include something in the east wing. It seems that that's not been an option that anyone has looked at, and no one has discussed it, no one has modelled it, and I'm frankly slightly surprised. Here is some real estate that could actually be really useful for the residents in the south of the county, and frankly the paper is silent on it, and I think that is a really missed opportunity, notwithstanding the first point that I made, that it's an MPFT paper, and then really what I'm talking about is strategic commissioning. Maybe people could pick that up.
Okay, if we pick, I think we'll take the first point as noted in terms of the insurance funding, if that's all right. I think Steve's covered that already. I think the second one around the strategic commissioning is something that I'll come back to Nikki maybe in a minute on that. But in terms of the overall health and care plan going forward, there is a requirement on the ICB as a new organisation to develop a health and care strategy for Staffordshire and Stoke-on-Trent, We have to do that over the next 3-4 months. We're already working with stakeholders in Staffordshire County Council, Stoke-on-Trent City Council, as part of the new Integrated Care Partnership that will meet for the first time later this month. And we have a number of stakeholders on that. So that is a strategy that we will be working through. We've already done a lot of work on that. Steve, as one of the directors of strategy across the systems, already been involved in starting to work that through. And I think that's where you will start to see some of that overall strategic commissioning as we move into this new world of the ICB, the Integrated Care System, and how we start to bring that together. How we link that then into the 2 place committees that we will have, and you'll be aware from the Integrated Care White Paper, we are looking at a place committee for Staffordshire and a place committee for Stoke-on-Trent, and how that will go forward. So there's a lot of work over the next few months to do in terms of setting that 5-10-year strategy as to how we plan our services, how we use our resources, and how best we take things forward. So that's a very general answer as to how that will sit over the top, and then these other things will sit underneath it. Nikki, I don't know whether you want to say anything specifically about mental health strategic commissioning going forward.
Yes, thank you, Paul. So in terms of strategic commissioning across mental health, it spans the whole sort of life cycle. So it is how we look at, the provision that we're making for children and young people right through to older persons. And there are lots of different elements within that have a really specialist focus. So things like perinatal mental health, for example, things about how we respond specifically to those in crisis, so how we work with ambulance services and others, etc. So it is a whole strategic picture that we look at in terms of how we meet those requirements and deliver those for our population. I think in terms of the points that have been raised, I think it's just to reinforce what's already, I suppose, been discussed in terms of very much strategically the provision for people with mental illness is about having community options first, and inpatient being the last resort, really, where it is that we just cannot keep people safe within their own homes. So very much the whole of the strategic direction is very much around how do we provide in the community, how do we provide the earliest options for people to get help as readily and quickly as possible, with reduced stigma, with reduced discrimination, so that they can seek the help in the way that they need to. And very much how do we do that for a lot of our communities that don't readily access mental health services currently. So we're doing a huge piece of work around what are the barriers that are currently in place to access for communities, and how can we address those, and that's part of our planning moving forward. So again, it's kind of trying to think about we absolutely will always need inpatient beds, but it's how we provide those in the safest way possible. And in relation to the option presented there about expanding on the George Bryan Centre, that would still remain a standalone psychiatric unit on what is a community hospital base. So it still wouldn't have the clinical benefits that have been described in the business case and in the presentation that Lisa so eloquently delivered earlier. If I can conclude there, Paul.
Yeah, that's great, Nikki. Lisa, I wondered if you could just come in and just re-emphasise the issue around the isolated unit and the clinical safety and so on.
Yeah, I mean, I think the important factor in that for me, Paul, there are two. One is about clinical safety, and as Nikki described, even putting other services on that site would not provide the level of support that's required, both from a clinical quality perspective or a safety perspective, because inpatient workers are specialist workers. They require specialist training that is different to what a community service would offer. And given that the George Bryan Centre is on a community hospital site that is not a mental health site, it doesn't have access out of hours to specialist practitioners with the skills that are required in mental health services. Any community services that we place there that were mental health community services, those staff also would not have the skills required to support an acute inpatient ward. And I think those are the key factors to think about alongside what Nikki described.
Thanks, Lisa. Thanks, Paul. Thanks, Nikki. Just let me come back on a couple of things. I take on board the points in terms of safety for an enlarged unit at the George Bryant. In terms of strategic commissioning, I welcome the fact that this is something that the ICP is going to look at, and maybe it'd be useful to align timescales so there isn't decisions in isolation, because otherwise it does feel like, for some of the Tamworth residents, they're being done too, rather than with the benefit of four. I also welcome the fact that there is this discussion with social care. If I was the county councillor for this area, I'd be saying, well, do we need to be looking at additional residential spaces, residential homes? It's something that we all talk about, the system talks about. Second of all, other ideas, we've got the award-winning Northfield Village, dementia extra care in Stafford. Is there a need in those communities for that sort of facility? I think having a disjointed discussion is really unhelpful because no one sees the end picture that we're all trying to get towards. So I would really welcome that joined up, system-wide conversation based on the needs of those local residents in the Tamworth and Lichfield and East Staffs areas, please. I'm not seeing any. I am. Mike Wilcox.
Thanks, Chairman. In your presentation, you go at great length to talk about big emphasis on treating people at home, and therefore in an environment that's more akin to their well-being. How confident are you that you have the resources within the mental health team to be able to react when you need to those individuals who may need care sort of immediately? And what sort of mechanism would there be then for us to sort of analyse how successful that has been and what the numbers are in relation to uptake on that, particularly in that part of the community? Thank you, Chair.
Thank you. Lisa, is that one for you initially?
Yeah, happy to pick that up initially. I think, as I said earlier, this is the first time that I've seen investment in core community mental health services that we've had from a national perspective. So I think in terms of the money that's been made available, I think it gives us a real opportunity to strengthen what we've got. But I think the key bit for me is in what Nikki talked about, which is about how we work alongside our partners, so the local authorities, the district councils, the voluntary and community sector, because there's an awful lot of provision that's commissioned to support people with mental health issues from a wellbeing perspective, and this is a real opportunity to join it up. So, I will always want more money, as Steve said, because we could always spend it, but we have to use the public funding in the right way. And this is about us investing, but also re-engineering what we've already got, because we already have a significant amount of money that's spent in community mental health provision. In relation to your specific question, I think that you asked about response times and seeing people quickly. We have been very fortunate to have a really well-resourced crisis resolution home treatment offer across South Staffordshire for a number of years that is assessed by the national team through the Royal College of Psychiatrists as being a really good model of service delivery. They have really clear targets in terms of expectations around how quickly they respond to people, particularly in urgent need, alongside our psychiatric liaison services, because we know that some people will go to A&E and we need to be able to respond to them there. So I think we're in a much better position than we've ever been with some of the investments we've had. we can certainly provide you some data on our performance around that, because they are areas that are managed through key performance indicators quite robustly. So that, I think, for me, gives me some assurance that we're able to respond as quickly as possible. We also work very closely with the police, with our community triage service, so that we can support the police if they are called out to support somebody whose primary issue is a mental health problem. So there's a real range of services there that can respond urgently to people who are in crisis. I don't know, Abid, Nikki, if you wanted to add anything from your perspectives.
Yes, thank you, Lisa. So I think from an ICB perspective, we do have a whole series of metrics against which we monitor our providers, and we do that at an ICB level, but also a place level as well, because obviously what we want to see is that that there aren't huge discrepancies in access for different parts of our population. So we have a whole series of different metrics that we measure MPFT against and our other providers. What we are doing is obviously building on those and refining those as part of the transformation programme. So looking at, waiting times, for example, for specific therapies. We're looking at outcome measurements, so implementing those in terms of paired outcome measurements for patients, and that demonstrate actually the difference that's making. So there is a whole sort of dashboard that kind of sits behind, underpins mental health services in terms of assurance that we can share.
Thanks. I think we would welcome just seeing some of those metrics that you offered. Yeah, we would. So let me just move on to Janice.
Yeah, thank you, Chair. It's on the back of that question, really. And Lisa, thank you for that. And also, my main question was about your involvement with the police. So I was pleased to hear you mention that particular part, because when you mentioned previously about the local partners, I would have thought they would have been one of the ones top of the list. I've been pretty satisfied with some of the other information that we're going to be hopefully receiving in the future, but one of them, and I'm not sure if it's one for yourselves or if it's something, Chair, that we would need to approach Staff's Police for separately, is just to get a bit more clarity on the community aspects and the police involvement with those. We've seen lots of information in the tables, in the data, about call-outs to the different centres, but actually if we're looking at trying to embrace the community side of things more. I think there was a comment about there was no reports, no significant reports, but I think it would be really helpful actually to see some evidence on that and to try and get some data to look at how the community side with the police is also being recorded. Thank you.
Lisa, is that one for you?
I think it's probably one for us and one for the police, because we, Staffordshire Police also collect a lot of data around primary issues associated with mental health, but we can certainly share the data from our community triage service, which is the key service that interfaces with Staffordshire Police. So I'm very happy to get that for you, but it's probably a question to ask through the PCC office as well, because we do work very collaboratively with them. As much as we can do across mental health services. So I know they collect lots of data, which I'm sure they'd be happy to share.
Thank you. Really good suggestion. We'll ask that through the police and crime panel next time they meet. Thank you for that. Richard Cox.
Thank you, Chairman. There is a question to come, but I think the comment is that I want to make is probably based on concern, actually, in terms of what's just been said. Actually, Janice and I may have been thinking alike there, in terms of the community safety that we have with wanting to be in the community, yet we're dealing with those that are severely mentally ill, and the unpredictability that brings. We can never truly work the situation out, because obviously the illness is evident, but we don't know what necessary actions will come from that. And obviously if you place more emphasis on the community, then are we looking at really being able to bolster the service up to ensure the wider community is also safe, as well as obviously individuals. So I think the question is, are you prepared for that? I think as well, in a sense, that I'm a little bit in the view of the proposal in front of us. I can probably see where you're coming from, but I can't relate it to anything that may have been discussed in terms of other proposals that might sit well with us as community representatives, that we can balance out and say, well, actually, yes, I see where you've come to make that decision. And a lot was said, of course, with regards to transport. You know, I don't think you have covered that. And I think that is a complex issue because of the fact that Staffordshire in itself is very much rural, and it's something that you've got to somehow square off, which I don't think you have. But it is the concern around the community and ensuring safety, not obviously, safety of even family members, safety of obviously those that are visiting, safety on a wider basis of somebody that may be in the community that might not be and may need that requirement of being hospitalised, even if it's for a short period of time, to assess exactly how vulnerable they are, but also vulnerability of the wider community. It is the unintended consequences that I think you've got to cover a little bit more. I'm not too sure we have that. It's always difficult to say what are the unintended consequences, but I'm sure that it wouldn't take, to understand there are always options and so forth that may be able to deal with those unintended consequences, because you might have a bigger problem in the long term than actually you have now. Thank you, Chairman.
Thank you. Go on. Sorry, Chair, I was going to say maybe Lisa could pick that one up first in terms of the wider context, Lisa, of the wider services that you offer and the work you do with other stakeholders and so on.
Yeah, no problem. So I think I'd probably start it off by saying that the largest proportion of people within the community who are being supported within mental health services never ever need to go into a hospital bed, and I think it's important that we acknowledge that. The majority of people are supported in the community and have been supported in the community for many years, and I'm sure Abid will add to that. From a community perspective, we've obviously talked heavily about the community mental health offer, the integrated neighbourhood teams that are wrapped around local communities alongside community and voluntary sector, alongside our local authority teams and alongside our physical healthcare teams. But we do also have a whole range of specialist teams that support people, particularly with issues. I think Nikki mentioned perinatal psychiatry, so those ladies who are in the latter stages of pregnancy that may have a coexisting mental health problem, but also those with small children that also need support. And again, most of that provision is provided within the community, within a person's own home. We also have eating disorders services. We've got specialist services, community teams that work with younger people with their first episode of psychosis. So there's a whole raft of provision out in the community that manages the bulk of the population, starting right from our practitioners who are working in primary care through to the IAP services, the improving access to psychological services, before you even get into the specialist end. So I think it's important that we remember that most people are supported within their own communities, and it's the smaller proportion that need support from those very intensive services such as crisis resolution home treatment, community triage alongside the police, and our inpatient provision. I don't know whether you want to add anything, Abid and Nikki, to that.
Lisa, you put it very eloquently. There's nothing to add other than, as I said earlier, majority of the people live at home with their families, with their relatives, and we do our very best to support them. That is why the hospital is small and it's a small part of their life when they come into hospital. We encourage them to achieve as much as they can, go back into work and education, or deal with the social issues out there in the community, and we try to support them in that.
I think it's just to say that obviously we, to the council, we have been delivering this model since the fire. So it's an important point you make around understanding unintended consequences. So I think we've done what, we've implemented various things to mitigate that through the hospital discharge team and those kind of other interventions. So I think there's always, again, it's been open to learn, isn't it? And it's been continuing to listen to patient and service user and family feedback, and to continue to do that is really important.
Thank you. Richard, anything further?
If I may just come back, I appreciate what you've just been saying there, and you've covered obviously some areas of mental health issues, which are obviously all very, very important to understand, and they because you're dealing with a human being and the problems that they are facing. Have you actually covered the situation where it might be in a small minority but nevertheless can actually have an impact on the wider community, of those that are suffering from split personality disorder that actually might not actually be suited within a wider community programme that actually should be looked at? Because I think we see many cases up and down the country where we've let slip certain individuals and so forth, and it's those ones that would be a concern that obviously discussions with the police would be interesting. Have you considered that, panel?
Lisa, is that one for you?
Yes, it probably is, yeah. So we have developed in Staffordshire and particularly in the south, and we've had many years experience of this now because it came into being pre-2019, where we developed a specialist community team to support people with personality disorders, but particularly those who present with high risk behaviours, because not everybody who has a personality disorder is a high risk individual. So we developed a very specialist community team to support those individuals, which is still in place now, which was built on evidence-based practice through a very structured clinical management approach, and we really invested heavily in that, and we've reviewed that and evaluated it, and that is part of our key offer going forward.
Thank you, appreciate that. Let me bring in Keith.
Thank you, Chair. And sorry if I some of this summing up, but for me, I like to go back to the beginning part.
You don't need to sum up. Sorry, Keith.
No.
If you were planning on summing up, I'll do that. But thank you.
No,
I know
I
you do like. I know you do like trying to become the chair.
I do try, Chair.
But let's focus on questions.
Can I just say, from my perspective, I'm looking at it purely as how sustainable the future service is going to be, how that's going to communicate to the rest of the population as a whole, not just necessarily to the south east that we're looking at today for this particular element, but across the board, because I think a comment was made that the funding was in fact across the whole of Staffordshire and not just for that area as well. And then how we can look at the way that these so-called in your own house sort of services and everything else are going to be able to relate back to primary care. And then finally, the one thing that I did quite like to hear was about the idea of getting some sort of qualifications out there for the voluntary elements that might be out there, which may include some of us. So that was what I would like to see out of it. I don't know what the other people want to see, but I was very, very encouraged to hear what I have been hearing today on some of those topics. Thank you.
And Keith makes a good point, because obviously there is a northern mental health provider who works out of Heartlands. So I would be interested in just understanding the breakdown, because it's not just about geography, is it? Who's picking the first bit up?
Sorry, Chair, there was, I wasn't sure whether that was partially a summing up or not. Which particular bit would you like us to pick up?
I think there is a question in part about the funding. Is the funding that was discussed, the £6 million, is that across the whole of the system, and does that include multiple providers? And what does that really mean in terms of the Staffordshire locality? I think that's probably the question.
The only other thing I did ask about was making sure that the communications, which we talked about much earlier in today's meeting, was going to be covered in the future.
Okay. We can pick those up. I think if I pass to Nikki for the one on the funding and the point really that yes, it does cover the whole of Staffordshire and Stoke-on-Trent, but it is only part of the overall funding available. And then secondly, maybe Jenny could pick up the one on involvement.
Yes, it's just to really emphasise that. So we have under the ICS Mental Health Programme Board, we have a community mental health transformation steering group where both providers sit, the ICB sits, voluntary sector rep sits. So we have Support Staffordshire there, who we specifically pay for a post to support the voluntary sector around community mental health transformation. We have our involvement leads sit there, both from North Staffordshire Combined Healthcare and MPFT, to make sure that we have our co-production. And we also have, we recognise the point around communications, actually, Councillor, and we have a dedicated communications lead now. And what we're trying to do is to get lots of information out there in terms of podcasts, in different ways of how we can kind of reach people. And interestingly, again, your point around primary care, we have Dr. Marie Campbell, who is a real advocate around mental health across the MPFT footprint, and he's going to be releasing some podcasts soon to make that more accessible. So we are looking at this very much as a partnership. So we do look at where we can look at things at a whole sort of ICB level, but then obviously there are sort of place-based focused areas that we need to respond to as well. But again, it's just to emphasise sort of Paul's point there that the 6.2 is across Staffordshire and Stoke, but it's specific to this specific transformation, and there's lots more investment that the ICB makes already in mental health, and will continue to increase that investment in subsequent years as well.
Thank you for that confirmation. That's satisfactory. It does bring me on to a couple of areas I'd just like to ask some very brief questions on. So, first of all, I note that there is a fully funded embedded mental health practitioner who should be in every primary care network. Can you let me know how many there are within Staffordshire's 23 PCNs, please, and how many specifically in the southeastern part, i.e. has everyone taken up the offer, and specifically in the area we're talking about, is that fully embedded and rolled out? That's the first question. Second question is, given a quarter of acute admissions, and that's on page 36 of the business plan, are not known to services prior to the acute admission, how do we know that we have seen or forecast the limit to what we're expecting in terms of capacity building, both from the pandemic, population growth and an ageing population? And the third question is, how does this align with the forthcoming mental health strategy? I.e., how can we be assured that when there isn't a mental health strategy in existence, but we've been promised it for a number of months and years, how do we know that what we've talked about today aligns with that strategy? Thank you.
Okay. Thank you, Chair. Nikki, I'm going to be really horrible and suggest you pick up all three of those. I don't know whether you'll have the data about the number of mental health embedded practitioners in PCNs. We may need to bring that back. And then the question on, I guess, the needs assessment and how we manage the numbers, and then the mental health strategy.
Yep. So in terms of the mental health practitioners, again, this is a nationally mandated programme, and it's an expanding programme. So we're in year 2 of this programme, and that's that every area should have 2 this year, and that will expand again next year. So I think it's fair to say we've done actually really well in Staffordshire and Stoke-on-Trent with the employment of the mental health practitioners roles. But I don't have the figures off the top of my head. I do think there was a specific decision made by the PCNs in East that they wanted to delay till this year because they wanted to have the funding that was associated with the two in play. So, but we're working really closely with PCNs and UPCAR, Gita, who's head of primary care for mental health for MPFT, is leading on that. But we can certainly get you the actual numbers that have been recruited and get you the detail on that. In terms of the needs analysis, we've done lots around at a PCN level in terms of what the needs are telling us at that really local level. And we've used the HEAT tool, which is the Health Quality Assessment Toolkit, to actually look at where we have sort of underrepresented groups and what actually we need to do to meet those needs. So that's part of the process. But you're absolutely right, there's always more we can do in terms of needs analysis. And I think that's something that we need to continue with. We have been working in partnership with Staffordshire County Council in terms of the mental health strategy, and it has been delayed slightly. So you're quite right on that as well. But we'll continue to work with our counterpart leads within the council to realise that. In recognition of that, the strategic ambition across mental health is very clearly outlined in the NHS long-term plan. So those are our sort of fundamental areas that we will work towards. So we continue to deliver against that. But I do take your point on there's an absence of a mental health strategy currently. Albeit we as an NHS are obviously working to that NHS long-term plan and continue to deliver that. But hopefully that mental health strategy will be realised very soon.
Thank you. That's helpful. Certainly, I think it'd be useful to see the numbers, particularly if we are talking about a model that involves greater community services. We just need to be satisfied that that all partners are playing to the same tune, and that picks up also the point about the mental health strategy. And I hope when we talk about aligning different strategies together, we look to align what's going on in the ground with the mental health strategy, because otherwise it makes a mockery of doing any of this, because it looks like the left hand doesn't know what the right hand's doing. Okay, I'm not getting any further suggestions that there are questions, detailed questions that we want to ask. So on that basis, let me try and bring this session to a conclusion and just summarise where I think we are. So first of all, thank you for coming this morning virtually, and for sharing with us what was a detailed presentation, but a useful presentation, because it summarised some 12 hours worth of reading and many years of professional experience from everyone around this table. So I appreciate, as does committee, the presentation. Also, thank you for your detailed analysis of some of the questions we've asked to allow us to undertake that scrutiny function that I think is really important and our residents would expect us to be undertaking. I think there are a couple of areas, and I'm just going to sense check with committee where they are. I think that committee is broadly in support of the move towards community services. Am I going to get a few nods around this room? This is hard work, this is. Go on.
If I could just respond to that one. No, I'm not at this point. I think that there's other information that we require. And one of my questions I was hoping you was going to follow up with now is given the published time frame, are we going to be able to receive some of that additional information, whether it's to do with transport and the significant concerns over there, the technology and replacing, complementing human contact? I think that there needs more clarity on that one too. Safety aspects, and given the published time frame, I think that we've got an awful lot, for me personally, to be satisfied before we start looking at some of those other milestones that are already there.
I mean, I'm in agreement with you. I wasn't necessarily going to suggest committee was going to be satisfied with the proposals in front of us. And I was going to go and touch on some of the areas of detail. It was the principle I was probably sitting with. I'll reflect on the suggestion there. I think, though, I mean, I'm going to try and get committee's sort of views on this. I don't think anyone's asked any questions on the principle of the decanting of people, you know, with dementia into the community and back where they live because of the benefit of doing that. So I think the work that you've already done in terms of the East Wing, I don't think anyone is significantly saying is the wrong move. Oh, this is a difficult meeting to read. I'm not getting any significant pushback on that. So I think, you know, we're with you in terms of the principle of doing that, particularly if it has benefits to those people who have dementia. I think there are lots of areas which we would like further input to, please, which go along some of the following lines, but not exclusively. The importance of raising awareness of the community offer and the patient pathway and the measures of success. There was a whole discussion on KPIs, which just frankly seemed to be lacking. There was a longer-term commitment that we were looking for in terms of community services. There was a need to see the clear transport policy that potentially impacted those people looking to visit due to a centralised site. There was a suggestion that the community services were ring-fenced, and again, we'd just like to see that in clarity. There was a suggestion about wanting to see greater detail in terms of the transport mapping, and a discussion of working on the strategic commissioning with all wider partners for what will happen with the George Bryan Centre thereafter, were you not to use it as an inpatient mental health facility, based on the local needs and aligning timescales within the ICP. We talked about aligning also the proposals here with the mental health strategy. So I think there is a whole bundle of stuff there that we would like to see. I'm just going to make one aside. No one's really talked about the process, but I have to say that me personally, and it may just be my personal view, that I actually was slightly disappointed that at a technical group review meeting back in December, you only had one viable option. The CCG came to committee in March and said that you were going to consult on the options, which is plural. And at that meeting, I was not under any view that there was already decided that there was only one viable option. And later that afternoon, later the same day, you're meeting with a reference group of specialists that agree there is only one viable option. I have to say that I feel rather frustrated that we should probably have had some of these discussions much sooner in the process, which is why I think committee are looking for greater information and input before saying that we would be happy to support you in principle with where you're at. Is that the view of committee? Oh, I've got some nods this time. They've woken up. So I think that probably gives you a steer, and I think that's probably where we'd like to leave it. And maybe you drive the timescale in terms of how soon you could provide some of that information for us to come back. Helen, I notice you're indicating.
Yeah, sorry, can I just make a point of clarity in terms of the presentation that we made back in March, which was held on the morning of the stakeholder meeting in the afternoon, that we came and gave a presentation with the report of findings from the October involvement activity, and we set out the steps for the next stage of the involvement activity, of which the stakeholder group was part of that process. We did not say that we would be consulting at that stage because we were still part of the options appraisal process at that stage. So I think there's a bit of technical terminology that we've got mixed there.
Yeah, I think this is, thanks for that clarity, Helen. I think this is all a learning exercise for all of us. I would say it would have been useful if you had relevant information to present it at committee, even if it's part of an ongoing dialogue. And I think that to me is the bit which feels like it was missing. It doesn't feel, if you were looking in from the outside as a member of the public, we could easily be criticised for not even understanding what was going on within your process and what was other discussions that were going on. And I think that's probably the point I'm making. I certainly feel frustrated by that. But let's, we are where we are and we need to move on, but please let's use that as a lessons learned. I don't want this to take away from the discussion today that I think has been really useful to better understand, the professional providers' views as to how we best serve the needs of our residents. Right, I think, Paul, have we given you clarity in terms of where we are?
I think so, Chair. I was just going to say thank you very much for inviting us today. I think it's been an absolutely excellent discussion that we've had. We've had sort of 2.5, nearly 3 hours, I think, of really, really good discussion. Some really useful and interesting questions that are being asked that will tease out some of the information that you need. I think between your support team and Jenny, I suggest we could tease out exactly what it is that we need to bring back. I think we would like to bring it back as a composite return to you rather than in dribs and drabs. So bring back as much as we can in one go. There may be 1 or 2 things that we need to wait slightly longer for. But if I could let Jenny and your support team just decide the timescale, and we'll commit to do that as fast as we possibly can. And then I think the next thing is, as you've outlined, Chair, is we want to maintain this engagement with you and this involvement so that we keep talking, we keep working through the issues so that collectively we can provide the most appropriate high quality, safe services to the residents of South East Staffordshire. And I think we're all committed to doing that. And I think thank you very much for having us here today.
Thank you, Paul. Just in response to that, preferably not another 608 pages, please, because it must take you eons of time to collate all that stuff. And likewise, I didn't get much of a weekend, but thank you for that. Paul, thank you to you and your team. Obviously, we should probably have welcomed you all to your new jobs, or many of you to your new jobs. But thank you for today's session. Thank you for rostering what is a very heavyweight team of senior professionals. So thank you for that. And let's be driven by the timescales as you outline. Okay, thank you. Please stay with us or go as you want, but thank you for your input today. So that just takes me on to the final item of the agenda, which is just to make committee aware that September's meeting is distinctly large and long. So we're taking a decision to put an extra meeting in the first week of October. I have a feeling it's the 2nd, but it's the 3rd. So I would be grateful if members could put that in their diary. And I wish you a safe, I wish you a good afternoon and safe journeys wherever you're going to. Thank you for your input this morning.